Okay. All right. So today we will have four consult station practice. So we will start with first candidate, Dr. Kalai. Are you there? Can you unmute yourself?
Yes, doctor.
Okay, wait. Let me see if the recording is started. Yeah. Okay, I think it should be fine. Okay. So you will have 4 minutes to prepare the first scenario. Okay. Are you ready?
Yeah.
Okay. Just give me some time. Okay, we'll bring the scenario out now. 4 minutes, start now. Okay, time's out, Dr. Kalai. This is the patient, Madam Nona. You may start now.
Hello, good evening, Madam Nora.
Yeah, hi.
I'm Dr. Kalai here, the doctor in charge of outpatient medical clinic. I've received a letter saying that you've been experiencing tiredness for the past 6 months. Can you briefly tell me what has happened?
Yeah, doctor. I have been experienced severe tiredness for the past 6 months. Generally, I feel my whole body is weak, and when I want to walk or when I want to do any activities, I feel no strength. I feel easily breathless, doctor.
Hmm. Is it
Yes, ah.
general? Is it generalized weakness?
Yeah, my whole body is weak.
Okay. Does it? Do you get tired at the end of the day, or this? Is there any timing towards it?
Not really. I feel tired a whole day after I wake up or before I
Mm.
sleep. It has been there for the whole day.
And this has been the first time you experienced it, right?
Yeah, I mean, this episode already lasts about 6 months, doctor.
Okay. Is it gradually worsening or is the same?
I feel it's gradually worsening. Initially, I just have a bit of dizziness,
Mm.
but now that I already feel dizzy even when I sit down.
Oh, okay. That must be disturbing. Anything that aggravates or relieves it?
Yeah, generally any activities that I do will actually make this weakness and also the tiredness worse.
Okay. You told me that you had dizziness. The dizziness is more towards positional change.
Yeah. Initially was positional, yes.
Mm.
Now even at rest also I feel the same.
Oh, okay. Do you feel your the surrounding is spinning or something like that?
Not really, but if I move too much, yes, I do
Mm.
feel my surrounding is spinning.
Okay. Any vomiting?
No.
Mhm. Okay. Do you feel nauseated?
Sorry, what's nausea?
Uh, feel like to vomit?
Oh, okay, no.
No, I'm not of such. Okay. Do you have any headaches associated with it?
Not really.
Not really. What about any shortness of breath?
Yeah. Especially when I try to move around or do any activities, I will get breathless.
Okay. Any heart racing faster?
Yeah. It all happens together if I do.
Together.
Mm.
Okay. What about chest pain?
Not really. I don't have any chest pain.
Okay, great. Any headaches?
No. You have asked me that.
Oh,
I
okay.
got no headache.
Sorry. Any numbness or tingling sensation you're feeling
Numbness over?
over your hands or your feet?
Yeah. I feel that I I I feel my hands and also my feet are actually numb, doctor.
Oh, okay. But you still can carry your normal daily routines as per usual?
Yeah, I still can, but I feel wobbly, when I try to walk. There's a few occasions that I almost fell down, doctor.
Oh, okay. I hope by the end of this conversation we can get to the bottom of it.
Yeah, sure.
Yeah. So, okay. Any one-sided weakness at all?
No.
Not such. Okay, great. Do you have any problem swallowing?
No.
Okay. Like to ask about your bowel habits now. Is there any change in your bowel habits? Do you have not vomiting or diarrhea?
No vomiting, no diarrhea.
Okay. Um, your bowel movement has been the same as in daily you have bowel output. You
Yeah.
still go toilet as per usual.
I have passing motion every day. I have no any change in the past few months.
Okay, great. Any tummy pain?
No.
No tummy pain. Okay. Any eye change? Any change in color of your eyes, or anyone told you that you're becoming more yellow or pale?
Oh no.
Mm. Have anyone noticed that you're becoming more pale?
Yeah. I think my husband has been telling me that I feel a bit white.
Okay. Um, do you notice any rashes in your body?
No.
No, as well. Okay. Any joint pains?
No.
Any oral ulcers?
Oral sores, not really.
Yeah, not much. Okay. What about your urination? Is it the same? Has it reduced in quantity or changed in color?
It has been same.
Yeah, it's been the same. Do you notice that you've been increasingly going to the toilet recently?
No.
Not of such. Okay, great. Do you have any loss of weight or loss of appetite?
Not really, doctor. But I did feel like eating lesser nowadays. It's just that my weight has been quite static.
Your weight has been quite static. Okay, that's great. What about any lumps or swelling that you've noted in your body?
Not that aware.
Not that you're aware of. Okay. Do you have any weather preference?
Weather preference, as in?
As in, you prefer cold environment or you prefer hot environment as
Oh,
such?
I think I I have no preference on that.
Okay. Has your mood been stable all the while?
Sorry, what?
Has your mood been stable all the while?
Mode. Yeah,
Mood,
yeah.
your mood. Yeah.
I don't feel any particular emotional issues.
Okay, great. Okay. Like to ask, do you have any allergies?
Allergic? No.
Yeah. No. Are you taking any medication at the current moment?
Yeah, yeah, doctor. I have
Mm.
diabetes and on two types of medication for the diabetes. One is
Mm.
called metformin, two
Mm.
tablets twice a day, and also another one is called glucoside, 30 mg twice a day as well.
Okay. When were you diagnosed with diabetes?
Oh, doctor, almost 15 years ago, doctor.
Oh, 15 years ago. Okay. And this medication, there's no newly started medication. It's been the old ones, right?
Yeah, yeah, he has been almost 10 years on these two medication.
Okay. No change in dosing as well.
No, no.
Okay. Can I know how is your control like? Do you
My
know your reading? Yeah, your readings of your sugar levels.
Yeah, yeah. I remember last visit to the clinic kesihatan doctor was
Mm.
2 months ago.
Mm.
For me,
It's a lateral thoracoscopy scar.
yeah.
The apex is placed and has a
Sorry,
trusting
I think
nature.
someone had
Sorry.
to
Yeah.
unmute that. Okay, so yeah, my sugar control is about.
Mm.
They told me it's about 7%, doctor.
7%. Okay. Do you take your sugar profile
It's a
daily?
loud pulmonary component of the
Yeah.
second sound. There's a
Yeah,
loud
let me
pulmonary.
just unmute it. Sorry
Yeah.
again.
Yeah. Do you take your sugar profile daily? Do you check your sugars daily?
No, no, no. I don't really check that.
Okay. Just wanted to ask you pertaining to your diabetes. Do you notice any bubbly urine so far?
Occasionally, yes.
Occasionally, yes.
Mm.
Okay. And you have numbness and tingling. What about blurring of vision?
Last time when I go to see the eye doctor, they told me got
Mm.
some mild eye problem, but I
Mm.
did not need to do any form of therapy.
Oh, okay. Do you know what's the problem like?
I'm not sure. I was told to be some that there is some diabetes issue over the back of my eye.
Oh, okay, okay. But you're still on the follow-up, right?
Yeah, yes.
Okay, great. Um, okay, great. Any other problems besides diabetes?
No, no.
Only diabetes, huh?
Hmm.
Yeah. Any over-the-counter medications, traditional medications you're taking?
No.
No, no herbals as well, huh?
No.
Okay, great. Do you sorry, are you menopause?
Sorry, what?
Are you still having menses?
Oh, I think my menses is almost finishing because I can
Ah.
see that for the past 2 months the
Mm.
menses been not regular, and sometimes it only comes like 2 or 3 days time.
Okay, do you notice any hot flashes? Your facial becoming more red?
No, no.
Not of such. Okay, great.
Mm.
Are you married?
Yeah, yeah.
How many kids do you have?
I have two kids, and both of them are actually quite small. But I'm staying with my husband.
Okay, great. Any pregnancy pills you're taking? Contraceptive pills or such?
No,
No. Okay. Any surgeries done before?
no.
Any family history of note?
Family history. My mother have
Mm.
diabetes.
Mm.
Other than that, not everyone else is is healthy.
Okay, great. Can I know what you work as?
Yeah, I'm actually not working. I'm a housewife.
Oh, okay. Sorry to ask you a sensitive question, but it's important for the diagnosis of your cause. Do you smoke?
No,
Okay, great. Do you drink any alcohol?
no.
Okay. I would like to examine the patient.
Okay. So, what do you want to examine?
I'll look at the hands for any palmar erythema, any tremors.
Okay. Hence, there is a palmar crease pallor.
Okay. Any colonychia?
No colonychia.
Okay. How about the pulses? Is regular rhythm?
Yeah, pulses. You feel it's a bit tachycardic. Heart rate is about 110.
Okay. I like to get lying standing BP.
Okay, good. As I told you that there is a postural drop.
Okay. I like to look at the face. Is there any rashes I see?
No, there's no
No.
rash.
I'll just like to check the visual acuity.
Okay. When you check the visual acuity over the right eye,
Mm.
you are using the Snellen chart.
Mm.
So patient as you go from top to bottom, the visual acuity over the right eye is 6 out of 6. And now you proceed to the left side,
Mm.
also 6/6.
Okay. I'd like to offer a fundoscope.
Examiner say you can skip for this.
Okay. Any auto source?
No,
No. Any neck swellings?
no.
No. Okay. Any vitiligo?
Yeah, no,
Bonding?
no vitiligo.
No vitiligo as well. Any acanthosis nigricans?
No acanthosis nigricans.
Okay. I'd like to check the heart.
Check the heart.
Yeah. So I'd like
Okay,
to check the
I see.
apex beat first.
Okay, apex beat is not displaced.
Okay. Is there any murmurs?
No murmur.
Okay. I'd like to check the base of the lung.
Okay, lungs.
Are fairly clear.
Clear.
Okay. I'd like to do a pinprick test for the upper limb.
Upper limb.
Mm.
Okay, when you check the pinprick test, you're going from C5, C6, C7, C8 is equal. But as you go to C8 and T1 as well as C5, as well as C6, it seems to reduce, especially at the tips of the finger.
Okay. I'd like to know where exactly she can feel the same as the midpoint. Yeah.
It can reach up to the wrist level.
Okay. Great. I'd like to do the same for the legs.
Yeah, for the legs as well, when you check sensation, you are checking from L2, L2, L3, L4, L5. As you go to L5 and S1, you notice that the base of the foot is also reduced in terms of pain.
Okay. Great. Can I know the proprioception like?
Yeah, proprioception is absent over the both legs.
Legs absent. Okay. Coordination.
Coordination, patient still able to perform a Hushin test.
Kirschin test normal. Okay. Any clonus?
No, when you check for clonus, there is no clonus.
Okay. Can I ask the patient to walk or stand?
Okay, good. When you ask the patient to walk, the patient is very unstable, but able to manage to stand up.
Okay.
Okay.
I'll just check
So-
the Romberg's first.
You want to check for the Romberg test?
Yeah.
Romberg test is actually positive. When you ask the patient to close the eye, the patient immediately almost fell down.
Oh, okay. I'll ask the patient to. I lie the patient down. I don't think I want to proceed with walking. I'll just ask a bit more history, Madam Nora. Can I know what's your diet like?
Normal diet, doctor?
Have you been? Are you vegetarian? Sorry.
No, I'm not vegetarian.
Okay.
2 minutes left?
Any change in your diet for the recent time being?
No.
No. Okay. Okay. So, Madam Nora, do you have any concerns for me today?
Yeah, doctor, I got a lot of concerns. Doctor, first question is what am I having, doctor?
Okay. I believe what you have is related to vitamin deficiency. Okay. Why do I say so? Is because you have. I've noticed your bloods outside. The GP has given me your blood results as well, and that shows your blood level is your red blood cells are a bit on the low side. And when I ask you histories, you have symptoms pertaining to low blood level, and I deem this is due to your vitamin deficiency and all the other problems that you just told me, which is wobbly to walk and you're unsteady, is related to it.
Oh, but what causes vitamin to be low, doctor?
It could be there could be a lot of factors associated with it. I believe in your case, it could have been. That's why I asked you about the diet, but you said there's nothing changed in your diet.
Yeah.
But it could be an autoimmune condition in which your own body cells, which are the white cells, are supposed to be protective against bacteria and viruses, unfortunately malfunction, and it's affecting your gut. So when it affects your gut, the absorption of vitamins is reduced.
Okay. Doctor, do I need transfusions from what you told me?
Yeah, since you have symptoms pertaining to low blood level, I think you need transfusion. You will be need to admitted after this, Madam Nora.
Oh, okay. Is this condition reversible?
Once we have detected the problem and confirmed the diagnosis, if it's the autoimmune condition that I just told you about, it can be reversed, but cannot be completely cured.
Okay, time's out, Dr. Kalai. So, Dr. Kalai, what is your list of working differential diagnosis as well as your final diagnosis for this patient?
So I've examined and clocked Madam Nora, who presented to us with lethargy for the past 6 months. She has symptoms pertaining to anemia, in which she has SOB palpitations, and postural dizziness. Besides that, she does have um, a sign of unsteady gait. And on examination, she has loss of proprioception. Rhombus was positive, and there's loss of pinprick, and there was a positive postural hypotension. Putting all this together, I think Madam Nora has vitamin B12, symptomatic anemia, macrophytic anemia, secondary to vitamin B12 deficiency, complicated with subacute combined degeneration with underlying pernicious anemia.
Okay. Other than what are the points that actually make you think of pernicious anemia? What are the supporting points in the history or examination?
Yeah, so the history-wise, I did ask regarding autoimmune features, signs and stuff, but she doesn't portray any. But the diagnosis of DM was 15 years ago, which is a bit young for her age. So I'm not sure that diabetes was diagnosed, is related to type 1 DM.
If let's say you think this is type
Mm.
1 then do you think it is appropriate if the patient is on two types of oral medication for so long?
I don't think so. You need to be on insulin.
Okay. So
Yeah.
what are the other possible causes of vitamin B12 deficiency?
Being a vegetarian, diet history is important. Other than that, I think of alcohol,
Okay.
any malnourishment, malabsorption, but she doesn't have any diarrhea or vomiting.
Mm-hmm.
Um, Other than that, chronic liver disease, chronic kidney diseases.
Mm-hmm. Not very common. Anything
Yeah.
else?
Uh, Maybe I'm not sure because she has complications arising from DM. It could be a malabsorption secondary to diabetic gastroparesis causing all these symptoms.
But you at least see for history there's no abdominal pain, there's also no
Yeah,
GI losses,
GI
right?
losses. Yeah,
Okay, never mind.
yeah.
Okay, never mind, you can proceed. So how do you investigate for this patient?
Okay, so I would like to do a serum vitamin B12 and folate.
Mm-hmm.
Okay, other than that, I've already have a full blood count
Sorry,
there
what,
already.
what is the result that you would be expecting?
I believe I think B12 will be low.
Okay,
Yeah,
and you expect for it to be normal, right? If it's
yeah,
a low B12.
yeah.
But let's say what B12 is normal, serum B12 is normal.
Okay.
What other tests that you can order to confirm your diagnosis?
B12 is normal. Since my uh, provisional diagnosis was pernicious anemia, maybe intrinsic factor level.
Okay, intrinsic factor level. That is to diagnose to know the etiology. What other antibodies that you know of that can actually help you to diagnose other than this?
Other than anti-intrinsic factor,
Mm.
antiparietal cells.
Okay, anti-parietal
Uh,
cell antibody. Okay, that
yeah,
will give you whether the patient have pernicious
yeah.
anemia or not.
But
But let's say your history and examination is suggestive of B12 deficiency, yet your vitamin B12 level is normal. How do you confirm the B12 deficiency then? Can this still be B12 deficiency?
it can still be because it fits the sign and symptoms. But I'm not sure how to elicit
Okay.
the yeah.
Okay. Any other tests you want to order other than those you mentioned?
I like to do a renal profile to look at the urea creatinine if there's any derangement there, and also electrolytes.
Mm-hmm.
And then she's already given me the HbA1c before, but I would like to redo again with the HbA1c FBS level.
Okay.
And then I'd like to do a nerve conduction study to confirm the peripheral neuropathy.
Okay.
Other than that, imaging, don't think I need any imaging though.
Okay, so time's up.
Yeah.
Okay, so you didn't manage to go into the discussion in terms of management.
Yeah.
But let's say if I give you some time, how
Yeah.
will you manage this patient just to complete the scenario? Yeah,
Yeah. I give IV cyanocobalamin.
IV.
Yeah.
Okay, all right. And how
Yeah.
frequent you want to give it?
How frequent do I give to give it? I think
Do we have IV preparation to begin with?
maybe I'm sorry. I think it's IM.
Hmm,
Yeah, it's IM. I think it's monthly, if I'm not mistaken.
monthly.
Yeah. I'm really not sure about the duration.
Okay. Other than replacing the vitamin B12, anything else that is important in this patient?
She needs a referral to the neurologist because I think she has SACT, and then besides that, an endocrinologist input, and then other management pertaining to her cause. mm, Will be dietitian referral for proper education on diets. I think that's all.
Okay, all right. Okay, I will end here. So how will you think about your performance in this scenario?
I can't really know what's the cause of the vitamin B12 deficiency. I know it's vitamin B12.
Mm,
Uh,
okay, that's number one.
yeah,
Okay, and are you going to exam soon
yeah,
in the coming diet?
yeah,
I mean, as in 2 weeks time?
yeah, yes, yes.
Okay, all right, sure. Mm, okay. Any other things that you feel you can do better?
Mm, Any other things?
Do you think from your history, do you think your history is complete in approaching a case of anemia?
Is anything?
So you look at the HB of 7.2.
Yeah,
Yeah, I mean, whether the MCV is given or not, there's something
yeah.
additional. But with the HB of 7.2 and the vital
Mm,
sign as such,
mm,
what is a very important thing that you didn't mention in the history? You asked a few systemic review questions, but you did not
mm.
ask certain important things.
Important things in us.
Hmm. So do you ask about any bleeding?
Yeah, I did ask about bleeding.
Yeah, so blood loss is something you must ask
Mm,
on every orifices. You must ask
mm,
got any bleeding from the nose, any
yeah.
vomiting. You say no vomiting, but any vomiting of a coffee ground
Mm,
color,
mm,
pass out any blood in your stool,
mm,
pass out in the urine, do you
mm.
have bruises? So all those are very important, huh?
Yeah, okay,
Because
okay.
you want to know why the patient HB is 7.2 and acutely MCV of 117 can be some form of so-called reticulocytosis with the acute blood loss, something that we don't want to miss. However, having said
Mm,
that, just for knowledge purpose, MCV of 117 cannot be due to reticulocytosis alone, lah. Because even with the patient that have full-blown, fully functioning marrow with 100% of reticulocytosis in the peripheral blood, the MCV at maximum also can go up to 115 only. So 117 is something with what we call as a sign of danger. I mean, it's a clue that this cannot be just reactive changes. This must be something else. Okay. Anyway, other than blood loss, you well aware that the patient have macrocytic anemia and symptomatic. And in terms of the association, and notice that you did ask about the gait, which is good. Okay, because you're thinking of cycle combined degeneration.
yeah.
Do you know other neurological manifestation for B12 deficiency other than the spinal cord?
Other than the spinal cord.
Hmm. If you ask me, I will tell you. But because you didn't ask me, so that's why I decided not to give you.
The angular stomatosis.
Okay, but neurological symptom, neurological manifestation, not the cutaneous.
Not sure, doctor.
Okay, so a B12 deficiency patient, you should
Mm.
indicate a few neurological symptoms. First is the
Okay.
gait. Okay, first is the gait and
Yeah.
instability, that's for sure.
Mm.
Second thing is the dementia. Okay, you must ask
Oh.
about whether is the patient getting a bit more forgetful recently. This is very
Okay.
important. Dementia can also caused by B12 deficiency. Third thing is
Okay.
optic atrophy, but sometimes you ask just to screen through the vision, any worsening vision, then you will know. Okay, but I'm not very satisfied with the way you asked about the spinal cord, the I mean the subacute combined degeneration symptom. So you asked me whether I have any numbness. I told you yes, but you need to differentiate that. Is this numbness is a manifestation for diabetes, or this is something else? So instead of asking numbness, you have to ask the patient, do you have any numbness prior to this? And then if the patient say no, so this is something new, then you know that it's significant. But let's say patient with uncontrolled DM in the past already got numbness, then when you ask the patient got numbness or not, definitely patient will tell you yes as well. So you should, a better way to ask is actually, first question, whether patient have any numbness prior to this. The second question is actually, is the numbness getting worse? Okay, because you won't able to differentiate whether this is, subacute combined degen or this is like diabetic peripheral neuropathy. Okay, and this is I can see that you try to ask about the gynae history, because given enough time, you should also ask about the menses, whether previously is regular or not, any excessive blood loss. Although 50 years old is almost reaching menopause, understand that, but you still need to ask whether patient can this patient have some form of excessive blood loss as well. Okay. All right. So just to go through your marking scheme. So I think your communication skill is fine, satisfactory. You can actually elicit the history. But the problem is that perhaps I will give you around borderline to satisfactory, because you do have certain things that you omitted from the history. For example, the dementia part in terms of manifestation, and also the blood loss. For this station, for a station, you cannot afford to exclude the history on any blood loss. It's very important. Okay. Examination wise, I can give you only borderline, unfortunately, because actually for this patient, your focus will be yes, peripheral examination, but your system, given that you not enough time, even if you really do one system also, you want enough time, probably you will just focus on the upper limb, lower limb, and also the gait. And then if you got time, you can also offer that you want to check for the heart to look for any signs of heart failure because of the high output cardiac failure, right? So probably I will just go by that. But your main dish is actually, again, is a neuro examination, because patient say got unsteadiness, and then you already well elicited the symptomatic anemia with the postural drop. But next thing is you need to elicit is the complication and the diagnosis. So you really need to examine the lower limb more. Yes, you examine the gait, you examine the Lambert test, but the lower limb examination is not complete. You just ask about sensation, pinprick, and also check for coldness. Okay, if you check this kind of patient, you should also check for power. I mean, just a screen through of power. You don't have to do a upper limb or lower limb. You can just, for me, I would actually should go to lower limb first, because lower limb is where all the signs are. Okay. Sometimes glove and stocking distribution, we all know that sometimes patient may not have glove, but that stocking is definitely will have, right? It's a bigger part of the body. So definitely I will focus more on lower limb, and I will check the power in general. And even before the power, I also try to feel for the tone, because it's quite fast. If you examine the lower limb, it's quite fast one. Ask patient to lie down, check the tone. At the same time, check for any clonus. If no, then check for the power. Power also won't spend a lot of time. And then check for sensation. Your main dish is actually pinprick sensation, and try to elicit the stocking distribution, as well as you want to check for any so-called stocking distribution. Yes. And then another thing is you want to check for your plantar response. This patient, if you ask to check in terms of the reflex, I will tell you that the knee reflex and ankle reflex is actually hyporeflexive. Yes, but then the plantar is actually outgoing both sides. That will really give a hint that this is a subacute combined degeneration of spinal cord. Okay. So you cannot miss the reflex as well. Okay, other than sensation. I mean sensation, yes, pinprick and proprioception. Proprioception in exam generally, if let's say you check the big foot, the big toe, and it's absent or it reduced, it is okay not to proceed with the ankle or with the knee and subsequently, because you need to tell that whether it's actually intact or absent. Okay. So we don't really have to spend our time to localize which level, because it doesn't really give any extra information other than positive or negative. So don't spend unnecessary time for that. But you need to elicit. Okay. And then after that, you can do coordination, but in this situation, you know, it's not very helpful. I won't bother to do a Hughes test. I will straight away ask patient to stand up and then check for rumble. And then if patient able to walk, I will assist and then check for whether there's any ataxia, sensory ataxia. And then also, I'll ask patient to do a tandem gait, in which patient will say cannot. And then you know that unable to perform tandem. Okay? So
Okay.
that's all for examination. And then probably in additionally, for this patient you want to offer, I will offer to end my examination to check for urine dipstick and also fundoscopy. I will just stop at that point. Fundoscopy for two reasons. First reason is want to look for diabetic retinopathy changes. Second thing is to look for any signs of optic atrophy to suggest BTL deficiency. Okay, so probably I will just stop here for examination. Okay, so for your clinical judgment, unfortunately, it's going to be unsatisfactory because you didn't get the diagnosis. Concern, no issue. I think there's a concern well. Physical signs, same as examination. If you got borderline for the A, B will automatically become borderline as well. Differential diagnosis, you will be borderline. Okay, welfare, you will get the marks. So in summary, you probably will fail this station. But I would say it's a good fail because you must know what are your weakness before you go for the real exam. It is always good to really underperform during the practice so that in exam you will be more prepared. Okay. So what are the possible differential diagnosis for BTL deficiency? You have mentioned that a strict vegetarian diet excluded. Okay, pernicious anemia very highly, very high yield as well in exam, in PACES exam. Generally, the patient will have some form of autoimmune like vitiligo. As you correctly asked, check for any signs of autoimmunity. Okay, be it a rheumatoid arthritis, SLE, or any form like even myasthenia gravis is also possible, and also some form of vitiligo. But let's say there's not much of autoimmune symptom. You also ask the family history to look for any autoimmune history. Let's say thyroid symptom also don't have, family history, autoimmune disease also don't have. So it makes the pernicious anemia less likely, right?
Yes.
So yes, you also ask about surgery. You remember to ask about surgery to look for any particular, for example, gastrectomy or sleeve gastrectomy, for example, that will actually affect the absorption of B12. Okay, you ask about that, it's also negative. So what are the other possible causes? Not much already, right? But there's some
Hematological cause, I think.
hematological causes. What kind of hematological causes? Actually, not common to have a B12 deficiency for hemato cause per se. Usually, they will have iron deficiency as well. Let's say it's a consumption hyperreactive marrow. So malabsorption, you also rule out. There's no GI losses. Okay. So again, back to the drugs. What medication patient is on?
Metformin and glycoside.
What are the side effects of metformin for long-term use?
Oh, long-term use.
Mm.
I'm not sure if it causes vitamin B12 deficiency, is it?
It will cause vitamin B12 deficiency. Guidelines actually recommend that any patient on metformin more than 1 year should actually screen for intermittent B12 level. Okay. So but don't forget about metformin can come out in exam because even in the case of pernicious anemia, if a patient is on metformin, even though you know that the anemia is secondary to pernicious anemia, you still have to offer a differential as possible metformin-induced B12 deficiency. Okay. So for this patient, the most probable diagnosis is actually metformin-induced B12 deficiency. Okay. And if you ask me further, there is a bit of forgetfulness. So there is some complication. As you correctly pointed out, when you try to give a full diagnosis, when examiner asks you about your differential and your provisional diagnosis, you don't have to summarize the case again. Unless the patient examiner asks you, so can you summarize what have you the positive features for this patient, including examination, and tell me what's the differential. Then only you go by that. But let's say if examiner asks you what's the differential and what is your most likely diagnosis, you just state your diagnosis upfront and with the supporting features from the history as well as examination to save the time. Okay. Okay. So I think for history it's okay. The only thing you forgot is properly to assess for complication, which is the forgetfulness. And then negative important things is the blood loss in which you didn't. And then hemolysis you did to ask. Yes, I can see that. And malabsorption you can also ask about passing of very sticky stool, difficult to flush kind of stool. Okay, or in any change in bowel habit. And then other than that, I think your history is fine. You remember to ask about dietary history. So remember, a lot of scenario you also need to explore not just drug history, traditional medication use, supplement use, illicit drug use. You also need to ask about diet and also lifestyle. Just to keep an idea about when you ask about social history or even something related, because sometimes that those are the components they may actually give some clue. Let's say this patient, if you didn't ask about dietary history, another similar patient that has mild association syndrome that has a celiac disease, if you didn't ask about dietary history, I mean she will say that anything you eat will actually make the diarrhea worse. Then if you didn't ask this specific question, you may not able to get that patient eating a gluten rich form of diet can actually exacerbate it. So you must really ask about dietary history. Okay. Another thing is for examination, I think it's fine. You can see that the calibration is mainly a neuro. Okay. And then the differential we have mentioned, we have discussed. So actually, other than because this FBC was taken don't know when, so it's also good when you mention about investigation, you should say or repeat the Fulbert count again. And at this point of time, I didn't mention here is you also need to take a GS group screen and cross match because you may need to transfuse the patient into a symptomatic anemia, which I didn't mention listed here. And also you want to also is worthwhile to take a peripheral blood film to look for megaloblastic anemia. Do you know what is the feature of megaloblastic anemia, especially in relation to B12 deficiency? Macrocytosis is here.
Macrocytosis, yeah.
And anything, the more important thing, the neutrophils.
Not sure of that.
Hypersegmented neutrophil, yeah. So
Hypersegmented.
the key, yeah. So you must actually say that you want to look for hypersegmented neutrophil in the blood film, and B12 for it definitely. So let's say the B12 is normal. If it's B12 is low, definitely this is an absolute B12 deficiency. But some certain patient can have functional B12 deficiency, meaning to say that the B12 is normal, but the precursor or the one step in the enzyme pathway is actually low. It is actually abnormal because the enzyme is not really working well. So those conditions, you should actually check for beta-malonic acid as well as homocysteine. Okay, these two will be elevated. So if this two is elevated but B12 is normal, this is what we call as functional vitamin B12 deficiency. Okay, they may also have symptoms. Symptom is regardless of this level. Basically, it's just anemia symptom. Okay, but this is something you should mention. If let's say examiner asks, then only you mention that. Also consider checking for beta-malonic acid as also homocysteine level. Okay, in folate deficiency as opposed to beta deficiency, because of the two different pathway involved, folate deficiency will actually get elevated in terms of the homocysteine level, but normal beta-malonic acid. Okay, as opposed to B12 deficiency, both will be elevated. Okay.
Okay.
So, and Schilling test is only for pernicious anemia. Let's say you're suspecting pernicious anemia, and don't forget to check for other concomitant nutritional deficiency. So iron study is also quite important. And then all the antibody you mentioned, the two, and you can consider NCS. So you also need to know, because B12 deficiency can come out in exam quite frequently, you also need to know how should you manage it. So it's not suffice to say just correct the B12. You should say how do you correct, because it's something quite reversible and urgently needed. So you should mention that we'll replace the B12 with IM, hydroxycobalamin. Okay, probably about 1,000 mic once daily for 1 week, and then twice per week for for usually we give 4 to 6 weeks, and then consider monthly injection. So you should actually load the patient first. So it's not suffice to say that just give beta deficiency like monthly like that. It's too slow. Okay, so yes, you can consider referral to endocrine, or you want to neuro. Okay, and then another thing is the rehabilitation part. So you should also mention about the rehabilitation, because patient have walking instability. Okay, so must make sure that the patient also have undergo some form of rehabilitation. Okay, so in terms of question, I didn't have time to ask all the question, but let's say the remaining 2 questions is actually quite expected. Do you think I have cancer? Do you think something is wrong with my brain? If you ask about the dementia part, okay? Okay, so just go through what are the differential diagnosis. Most of it we have discussed. So another thing to actually classify B12 deficiency, an easy way is to divide into these 4 possibilities. First is the intrinsic factor pathway. It can be, usually the pathology is either pernicious anemia or something wrong with the stomach level, the intrinsic factors production in the stomach. So pernicious anemia is definitely one of the top differential for B12 deficiency, followed by all the stomach problems. So can be some form of H. pylori infection, peptic ulcer disease causing atrophic gastritis. That actually itself causes reduce in intrinsic factor production, or surgery that remove the stomach, gastrectomy, or sometimes not inappropriate secretion, which is a high secretion in gastrin, let's say in gastrinoma in relation to MEN1. So MEN1 is also one of the manifestations pancreatic lesion, right? So gastrinoma can also cause beta deficiency by causing Zollinger-Anderson syndrome. Okay, and the fourth and the last one perhaps is the pancreatic insufficiency because of the impact in terms of binding. And dietary is what we must ask as well, vegan. And the third one is malabsorption syndrome, which most of the pathology is actually at the level of terminal ileum. So you must also rule out, for example, IBD, celiac, TB, or even lymphoma. So must screen for constitution symptom, any fever, any sweating at night, any loss of weight. You did ask about loss of weight, loss of appetite, not a problem. Okay. So SIBO is also another possibility. Let's say patient have a risk factor. And if the patient you must also explore whether patient got any high risk behavior as well. Sometimes beta deficiency in relation to HIV patient is quite common as well because they have malabsorption. So and the last one is actually the drugs. Don't forget about drugs. Certain drugs, the common one is actually being not the metformin but the alcohol. Alcohol patient can present with very chronic alcoholism, came in like reduce responsiveness, and then after resuscitated was stable. Subsequently, you take the further history, and then you get all the vitamin B12 deficiency symptoms. So alcohol can be one of the possible culprit as well. And then PPI is questionable, but yes, there is more and more studies showing that long-term use of PPI will cause beta deficiency. Metformin is something we need to make sure we must include in our differential. Okay, all right. So we will proceed to the second scenario if no one have question. Kala, you okay?
Yeah, doctor. Understood. Thank
Okay.
you.
All right. Thank you for participation. So second scenario will go to Dr. Tan. Dr. Tan, are you there?
Hi, doctor. I'm here.
Okay. All right. Are you ready to proceed the second scenario?
Yes, doctor.
Okay. All right. Sure. We'll give you 4 minutes from now. Okay, Dr. Tan, 4 minutes is up. This is the patient, Miss N. We start.
Hi, good afternoon, Miss Anne. I'm Dr. Tan. I'm one of the doctor in this clinic. Miss Anne, I just first of all double check. Are you Miss Anne, 43 years old?
Yes, doctor.
Okay. I received a letter saying that you have been feeling sick and vomiting for the past 1 month. Do you mind to tell me more about that?
Yeah, doctor. Actually, I have been unwell for almost 6 months, and I only felt very sick in the recent 1 month, and I feel easily want to vomit, as well as feeling headache, especially when I wake up in the morning. So I also have a lot of issue, doctor. I have also have weight loss for almost 1 kg in the past 1 month.
I see. There must be a lot going on in your life. I hope I can help you better by the end of this consultation. I'm going to ask you a few questions so that I can help you better. So
Yeah,
you've mentioned, yeah.
yeah.
Uh,
So
s- so you mentioned that you have been feeling sick. Is it gradually started on for the past 1 month?
I would say intermittently. Sometimes I feel like want to vomit. Sometimes I don't.
I see. Is it anything make it worse?
I'm not sure actually, doctor.
After food, is it you feel you vomit after food, anything like that?
Not really. I was
Not
fasted
really.
actually. Yeah.
You're fasted. No specific food make it worse as well.
No.
No. Okay. All right. And then I would like to ask how many times a day you vomited?
Sometimes can be up to 2 to 3 times, doctor. But
Two
sometimes I
to
just
three.
feel got sensation, feeling want to vomit, but I didn't vomit out.
I see. Is it any the vomiters? Is it food particles or any blood?
Generally just clear fluid. There's no blood.
Clear fluid, no blood. Okay, I see. Any difficulty swallowing?
No.
No difficulty swallowing. Chewing? Any problem?
No.
No. Any tummy pain?
No.
No tummy pain as well. Any change in the bowel habit?
Change in the bowel habit, as in having diarrhea or anything.
Yeah, having diarrhea or constipation? Any change in the pattern?
Yeah, I noticed that I do have a bit of difficulty to pass motion. My stool is quite hard. Sometimes I have to strain for some time.
How long has this been going on?
I think it was almost 3 months now.
3 months now. Difficulty passing.
Hmm.
Okay, I see. And then when you vomit, any bloods coming out?
No.
No bloods coming out. And you said you lost weight.
Yeah, doctor. But I'm actually, to be honest, my weight is as at the higher side. I was 85 kg. Now I'm 84 kg. Lost about 1 kg for the past 1 month because my appetite has been reduced.
Okay, I see. Have any history like eating outside food or and then it triggers all this?
No, no,
No. Any raise in temperature?
no.
No raise in temperature as well. Okay. Any lumps and bumps anywhere else in the body?
Not that aware.
Okay, I see. Now I'm going to ask you more questions so that I can help you better. Do you have any? You mentioned that you have headache. Where about is the headache?
The headache is, to me, is not really specific because sometimes it comes usually early morning when I wake up.
Is it the most severe headache you have?
No, no, it is quite mild one.
Or quite mild one. Okay,
Mm.
all right. Okay, when you like cough, is it where after you cough, the headache getting worse as well?
No, no,
Something like that. Any blurring vision,
no,
any dry eye, red eye, or greedy eye?
no,
No. Any rashes anywhere else in the body?
no,
And no. What about like rashes, especially when you go out the sun?
no,
No. Any sore in your mouth anywhere else?
no.
No. Any lumps and bumps at your neck area?
You ask me, no,
No. Okay, all right. Any intolerance to hot or cold weather?
no,
No. Any tremors?
Tremor as in shakiness? No.
Shakiness? No, don't have. Okay. How was your memory?
My memory, I think is fine.
Your
Sometimes I
memory
can be,
is
yeah, sometimes when I wake up, I can feel a bit dizzy. Sometimes I do forget things, but usually I'm okay.
okay. All right. Any difficulty breathing?
No,
No. Any chest pain?
no,
Any joint pain anywhere else in your body, including back pain?
no.
How's your water works?
I can pass motion, I can pass urine quite well. No issue in passing
N-
urine.
No pain as well. No change in colors in the urine.
No,
Nothing like that.
mm,
Okay. All right. Have you been travel anywhere else recently?
no.
No. In the letter, I noticed that you have a bit of a mood problem as well. Do you mind to tell me more about that?
Yeah, doctor, I have depression for almost 3 years already, doctor. So I actually try to live through every day. I'm not on any medication. Sometimes I do take a bit of over-the-counter paracetamol because I feel unwell. But generally, I didn't take more than 6 tablets per day.
No more than 6 tablets per day. I
Yeah,
see.
yeah.
Okay. All right. And your mood, I understand that you have feeling like down throughout, but is it getting worse?
I think I'm still coping. I
You
think
still
still okay. Yeah.
still coping and still okay. Like you do you like uh any difficulty like sleeping or anything like that?
Yeah, yeah. Talking about sleep issue, I will sometimes when I feel sad, I will drink some alcohol and then only then I will sleep well after.
I see. Do you mind to tell me how many like alcohol do you drink and what types? How often?
Yeah, so if you ask me, I actually usually drinks uh about 2 glasses of gin with tonic every day and night to help me to sleep after for the past 1 year.
I see. It must be difficult. I hope at the end I can refer you someone so that we can help you better. And you
Yeah.
mentioned that the depression you only take paracetamol, but you didn't take any other medication, right? Have you ever seen any mood doctor also?
Mm, I refuse to see them after I saw a few
Sure,
times because
sure,
I
sure.
don't feel like doing that. Yeah.
I'm sorry to ask this sensitive question. We ask to all patients. Do you have any thoughts like to harm yourself for now?
At the moment, no.
Okay, all right, great. So just ask you some social. Oh, I understand that you drink, and what about like do you smoking?
No, no, I don't smoke.
You don't smoke. Okay, are you working person?
Uh, I work as a cashier, but because of all this issue, I recently cannot really focus at work.
I see. Must be difficult for you. And I noticed that you have two children.
Yeah, yeah, I got 2 kids.
You
I'm a
got two
single
kids.
mother daughter. Yeah.
I see. I see. And then do you have sorry okay, all right. So I would like to ask have you take any party drugs?
No, doctor, why do you think I take party drugs, doctor?
Oh no no, we ask to all patients because just to make sure we do not miss out anything important.
Oh, okay. No, 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 I didn't.
Okay, okay, you didn't. Okay, all right. So, okay, great. And then, any illnesses that runs in the family?
No. My
No
father
ill.
did had some heart attack in the past, but other than that, there's nothing that I can recall.
Sure. Other than having mood problem, do you have any other illnesses that I should be aware of?
No,
No, as well. And other than paracetamol, you are not taking any other medication,
no.
either like oral form or injectable form. Nothing like that.
Uh, Injectable meaning?
I mean, inject or uh, any like medications over the counters.
No, no,
Nothing like that. Traditional meds also don't have. Okay, all
no,
right. Are you allergic to any medications or any food?
no.
Have you been admitted for any reasons?
No.
No as well. Okay, okay, all right. Would that be okay if I examine you?
Yeah, doctor. So what do we
So,
want to examine?
so I would like to see the patient in general,
Mm-hmm.
whether the patient is well built. As doctor, you mentioned to me that she's about like 84 kilos. Like whether she looks cacatic, whether pallor, jaundice,
She
yellowish
look,
skin.
yeah, she look a bit obese with a BMI of 30.
Okay, and then I would like to examine the hand. First of all, like, I would like to look at the fingers, any new changes, chronicia, leukonychia, and then check the hand whether there's any hysteresis, wrapping tremor to biting contracture,
Okay.
clubbing.
There is palmar erythema when you check the hand. There's also mouth clubbing, but there's no hysteresis, there's no dupuytren contracture. There
Okay,
is there is a bit of spider nearby over the forearm, but
okay,
there's yeah,
I see. And then I would like to feel for the pulse.
pulse is regular, good volume.
Pulse, good volume. Okay, all right. Then I would like to examine the eye, whether there's any pallor or jaundice. And yeah, pallor, jaundice, and
There is tinge
corneacus,
of pallor.
calcification.
There is tinge of on this, but no pallor.
No pallor. Okay, all right. And then I would like to check the angle of the mouth, whether angular stomatitis, and then oral hygiene, and feel for the parotid gland as well.
Mm-hmm. I mean, oral hygiene is fair. There is no oral ulcer, and then there's no parotid gland enlargement.
No parotid gland enlargement. No angular stomatitis also.
No.
No. Okay, all right. And then I would like to gently feel for the neck, for thyroid and lymph node, if there's any.
No.
No. Okay. Then I would like to auscultate the lung and then quickly feel for the apex beat and listens to whether there's the CBS, whether there's any murmur.
Okay, heart apex beat is actually normal, not displaced. Uh, when you escort it, there's no rhythm, no murmur. When you escort it, the lungs, it's actually clear by basally.
Sure. I would like to look at the abdomen, whether
Mm.
it's distended, whether there's any striae.
No,
And then doctor, also the arm, when I examined, there was no any like needling injection mark, right?
no,
No. Okay, all right. So no, then I would like to, do you have any pain in your tummy? Then I will feel around.
no.
Then feel for any hepatospleen.
Okay, when you palpate the abdomen, there is a two-finger breath hepatomegaly, but there is no splenomegaly. So when you
Okay.
check for shifting downwards, there's no ascites felt.
Okay. The liver, is it painful?
It's not
Tender?
tender. It's not
It's
tender.
not, it's not tender. And then the bowel sound, is it
2 minutes
normal?
left.
Bowel sound, is it normal?
Yeah, bowel sound is present.
Okay. And then no pedal edema and rashes anywhere else in the body
Yeah.
during examination. Okay. All right. So can I ask, do you have any specific question that you would like to ask me?
Yeah, doctor, what is wrong with me, doctor? What are
Okay.
the symptoms? What causes all these symptoms, doctor?
All right. So you basically came to us because you feel very sick, and then there was vomiting, and then we have did the liver function test, the blood test for you. We noticed that we called it a liver enzyme. Basically, there were some biomarkers over your liver. There are some of them are deranged. So first of all, number one, I'm thinking that it could due to the alcohol that you take. I understand that you have a mood problem and then you drink a little bit more of a gin tonic that you mentioned about like 2 bottles per day. So for now, I would like to advise you to cut it down and stop if possible. But understand definitely it's difficult. So if you don't mind, I we have mood doctors in our hospital. I can refer you to them, and then there are counselors also in our hospital, so that they can help you better with your mood. So that they help you with your mood. With that, we hope that you can cut down the amount or even stop the alcohol habit. Would that be okay with you?
Okay, so doctor, why am I having? Is it due to alcohol?
For now, I'm thinking that one of the causes could be alcohol.
Mm.
And also, of course, I would like to screen for other problems as well. Sometimes, like some viral infection over can cause the liver
Okay.
enzyme to
All right.
be abnormal as well. Yeah.
Okay, time's up. Okay, Dr. Tan, would you mind to tell me what is your differential diagnosis and your most likely diagnosis?
Okay. So, doctor, I think my first probable diagnosis for this patient is I'm thinking that patient having alcohol hepatitis, secondary to underlying depression in this lady.
Okay, and then what are your differential?
Mm, I would like to rule out viral hepatitis, and then I would like to rule out other causes such as like hypothyroidism, but it will be down the list.
Okay, in relation to the liver function and also the patient's symptom, what are the other possible causes for the liver condition?
Sorry, doctor, can you repeat the question again?
Yeah, in relation to the abnormal liver function as well as the patient's presentation, other than alcohol, is there other than alcohol and viral hepatitis, is there any other etiology that can offer as part of the differential?
Mm, maybe I can rule out whether there's any primary biliary cholangitis and primary sclerosing cholangitis as well.
Okay, but there's no much of autoimmune
No,
symptoms you can
no,
elicit, right?
yes,
Okay,
yes.
how about the patient weight?
The patient, she is slightly, she's BMI is increased. However, she did lost 1 kilo over a month. I think due to the vomiting.
Okay, what does the weight tell you? Can it be some form of in connection relationship with the possible etiology?
Initially, I was thinking, could the patient having hypothyroidism that caused this as the weight was slightly on the high side, and from the history, patient did have a little bit of constipation, but I forgot to ask about the menses. But she clinically there was no any swelling over the neck, no tremors.
Okay, never mind. How will we investigate this patient?
I would like to start off with routine blood investigation. I would like to send for full blood count to see whether there's any component of anemia, raised total white, and thrombocytopenia. I would like to get a baseline use-and-E liver function as above. Um, I would like to screen for viral hepatitis A, B, and C, including HIV as well. I would like to send off CRP ESR. Maybe I can consider to send off autoimmune workup such as is it anti-asthma and then LMPK ANA for this patient as well. And then I would like to arrange for ultrasound HPS for this patient. I would like to send for thyroid function test for this patient as well, doctor, and including lipid profile and fasting blood sugar.
Okay, how about any imaging?
Ultrasound HPS, if I can found some abnormality soon, maybe I can proceed with CT for face pancreas.
If you found a stone, do you proceed with CT scan?
No, no. I think it's ERCP. Get gastro input. Whether I can perform a ERCP.
Okay, all right. So let's say this patient has an alcoholic liver disease. How would you manage this patient?
Okay, I would like to use a multidisciplinary approach. Number one, I would like to start off with non-pharmacological input. As a patient for this case, she did have depression and she's a single mother. I need to get the social support. I would like to refer her to the social service, and then I would like to get the counselor helped for the mood counseling, and then get the dietitian involved as well to provide adequate nutrient for this patient. And then subsequently, I would like to refer to a gastro team whether there's any scope needed or ERCP needed if I found any stone from the scan. and then I would like to refer to the psychiatrist to start the patient's appropriate medication for antidepressant, and then monitor throughout, as now she relies on alcohol, and she take about
Okay, time's up.
paracetamol. Yeah,
Okay, but you can continue. But you can see, generally when the time is up, is your lack of time already. You should focus the main one. In
yes,
relation
yes,
to alcohol, what can you do other than mentioning all the non-pharmaco first? You
sure,
must
sure,
mention the
sure.
important thing, right? So how about alcohol? What is your management in terms of alcoholic liver disease?
Um, Alcohol abstinence, then subsequently, um, if they have alcohol dependence, maybe we can start off with diazepam, doctor, to cut down. And if clinically patient have any like withdrawal, then we can replace with vitamin, IV parental white, and then thiamine for this
Okay.
patient.
Okay, so there are a few things that you mentioned. Do we give diazepam in patient with alcoholic liver disease?
Maybe not unless they are in unless in withdrawal, and no. Sorry, doctor. Actually, I'm not too sure about this.
So actually, so you can say that the management can be divided into a few different phases. First is the
Okay.
patient. So at elicit, when is the patient last drink, in which the from the history you didn't elicit lah. So let's say
Yeah.
if the patient last drink is actually less than 5 days time, I will need to watch out for signs of alcohol withdrawal. Okay, to prevent for delirium tremens. So I will start patient on feed charting. I will make sure patient receive IV parenteroid, high dose thiamine. Okay, I will also, if patient develop any signs to suggest tremors or withdrawal symptom, I will refer to the psychiatric colleague and also consider starting lorazepam. So in withdrawal
Okay.
state, we don't give diazepam for any patient with transaminitis or so-called liver derangement, because the reason is diazepam is metabolized in the liver lah. We don't want to actually make the condition worse. So usually they give lorazepam instead of diazepam lah. Okay. But if you want to be safe, you can mention that to consider benzodiazepine for withdrawal, alcohol withdrawal. But if you want to mention about types of benzodiazepine, then you need to make sure you know what you're saying lah. You cannot mention about diazepam in this kind of patient. So
Sure.
usually if you refer psychiatrist will always start Lola, they will not start diazepam. Okay. Another thing is that, so after the withdrawal part settle, so next comes the management of the dependence, the alcohol dependence. Yes, you say that refer to the psychiatry for counseling on the addiction and for the support group. Okay, you can mention about the social welfare referral and also considering any form of financial aids for her if you're a single mother. Okay, and also you can also consider screening for HCC surveillance by doing alpha fetoprotein and also ultrasound at ultrasound HBS. Okay, by right it's actually CT 4 phase lah. But let's say ultrasound is normal, then by right you didn't need to proceed with that. Okay, and probably that's all you can mention within the probably 2 to 3 minutes of discussion with the examiner. Okay, I think
Okay.
your pitfall was actually you are. It's good that you're taking your time and your pace in presenting. That is a good point. But sometimes if you want to do that, you have to be a bit more concise. Okay,
I
like
see.
let's say when you ask about the patient concern, when the patient asks you what do I have, the way you answer is not wrong, but you didn't really directly answer the patient. What you answer is like suddenly you answer about alcohol, and suddenly you ask patient to stop alcohol or cut down the usage. Suddenly you ask to refer to the addiction part, but you didn't answer the question that what do I have, doctor? You can see that. So
Okay.
to answer, you know that our concern usually got 4 or 5 questions for the new format. So you need to answer short and sweet. So what do I
I
have,
see.
doctor? You can say that at the moment, I think your symptoms are all attributed to possible alcohol-related liver disease. Okay. So for that, we need to do further workup. I might need to admit you for a while for observation. Just like that. Very sweet only. Okay.
I see.
Then only when you want to talk about cessation alcohol, all those things you can, but make it short so that you give some time for the surrogate to ask you more question. Okay, or else you won't
Okay.
have enough time for the concern part. Okay.
Okay.
So other than that, for your own comments, do you have any comments on this scenario?
Mm, no, I just have difficulty to come up with differential, doctor.
Differential. So, I I have a few comments initially, but I can't really remember. We will go through
Yep,
as we
yep.
go along. So,
Sure.
but from what you from your presentation, I think it's fine. You can get satisfactory for com skill. Examination, you're also good. You examine the abdomen, the peripheral examination. I think that's also fine. Clinical judgment, unfortunately, I can only give you borderline, but actually,
No
certain
problem.
examiner may give you satisfactory as well because the differential diagnosis is not complete. Okay,
Yep, yep.
concern not an issue. Vital sign, physical sign, I suppose satisfactory as well. Differential, you probably will get about borderline, but welfare,
Mm-hmm.
you will get full marks. So probably you're not too bad, I would say. You can actually, if you able to think through the differential and able to mention it, then perhaps you may able to get full marks. It's just that your flow is a bit slow. You need
Okay.
to you need to
Fasten.
uh you can keep your current pace. It's just that you need to be more thinking ahead. You need to be more concise, more short in answering question and also your presentation. Okay.
Sure.
So most of the history you got, but you didn't ask about the jaundice history. Yeah, I was expecting you asked me about any jaundice,
Yep, yep.
but I
Yeah,
didn't
I
manage to
miss it.
listen there, right? Yeah, you missed
I
it, right?
miss it.
Okay. Okay. Next is actually constipation. Yes, the drug history also I offer you. You need to really elicit the drug history, especially in the case of abnormal liver function test. Okay. And you did ask about abdominal pain, the tummy pain. You also need to ask a bit more specific question because this symptom has been there for 1 month and unwell for 6 months. You have to rule out the component of chronic pancreatitis, which also can present as recurrent episode of nausea and vomiting, right?
I
So
see.
you need to ask about whether there's any passing of stool that is oily or greasy, difficult to flush away, or do you have any pain specifically related to which actually radiates to the back? Okay, and then in terms of the hepatitis history, you asked me only about traveling, but you did not ask me about any blood transfusion, any needling, any ear piercing, any tattooing. So all those things
Yeah.
must go together. Must go together. And we
Doctor,
ask about.
can I ask a question? Because I actually want to ask, but I was worried to ask because I remember when I asked about like um I asked very indirectly as because I feel like the patient sort of like offended. Oh, why you ask me this? I
Yeah,
remember.
yeah.
Yeah. So like how do I that's why I asked, right, do you take any other medication in form of oral or injectable? Actually I want to ask like IVDU.
I
I
know.
checked yeah, so I didn't know because she is depressed and then she is taking alcohol and depends on that. I mean alcohol dependence, so I find it very difficult. So is there any tips that I could have asked better?
Yeah, so actually it's very simple. You just need to plan how you ask the question.
Okay.
So
Okay.
when you give a warning sign before you ask all these sensitive questions, you did mention, right? You mentioned that I'm sorry to ask a few sensitive questions, but I asked in all my patient. So you must
Okay.
give them a warning shot first. And then the moment you mention about this opening sentence, then following question, all the sensitive questions you ask all together. Like you cannot ask
I see.
suddenly you
Yep.
you putus a bit and then you ask about other thing and then suddenly you ask
Okay.
back some question. So
Sure,
you must
sure.
ask everything like high risk behavior thing you must really explore. And because you have a bit of hesitancy to ask, you didn't explore about any unsafe intimate relationship,
Yeah.
which may suggest HIV. Because this kind of patient are very what we call as uh they are very vulnerable. Okay. So it's important to explore that. So it is very simple. You just ask the patient, I can see that you are going through a lot of things at the moment. However, I have a few sensitive questions to ask you. I hope you don't mind. I do ask in all my patient, is you okay? Then the patient definitely will say okay one. Okay. Then only then
Okay.
you slowly ask, do you have you ever try to take party drugs? Have you ever tried any injections or any illicit medications through the blood or any injection? Have you traveled to anywhere recently? Have you have any unsafe intimate relationship? Have you underwent any ear piercing procedure or any tattooing in the past? So you have to ask all that together. And then when you ask about the alcohol, you should actually try to quantify it. Okay. try to quantify it in the sense that how many units per week. So the patient say that every week, every day has been drinking 2 large glass of gin with tonic. So that itself will contribute like almost 5 units per day. Then then how about weekend? You should also ask about, is it same for the whole day, whole week? Then you'll say that, oh, probably in the for example in the weekend doing more things like that. So you must try to at least no need to know how to calculate, but just roughly know that this is more than 14 units. Then you know that this is already harmful drinking. Okay, so if I don't know about the new format. But let's say if you have time and this is really a case of alcohol related condition, then you really need to try to elicit the case questionnaire. Okay, it's actually quite short, not difficult. You just ask cage, right? CAGE. So the first thing is actually to ask actually does the patient feel like I can't even remember the C start with what. I
Cut
will
down.
always to
Cut
cut
down,
down.
right,
Yes.
doctor?
Have you ever wondered whether you want to cut down the intake, the usage of alcohol, and have anyone actually get annoyed with you drinking, or actually the exact question is actually have you get annoyed with yourself for drinking that much of alcohol instead of other people feel annoyed lah. The actual question is actually from the patient perspective, and then do you feel guilty of doing so? And then is the alcohol is the main thing you think of when you wake up early in the morning? If you ask me that, I will say yes. And when you try to ask what causes the vomiting, right? Is it any relation to food, right? You should actually ask. Sometimes the patient may not admit that, okay, actually it's because drink too much overnight and then the next morning feel like want to vomit. So sometimes patient may not tell you that. So you need to ask that. So the moment patient is episodic, intermittent vomiting. So the moment patient say early morning feel like vomit, you should automatically ask the patient, oh, does it happen? Does anything happen the night before? Do you do anything or drinks anything? You can try to ask. If you get that the patient have alcohol intake the night before and morning sickness or even like morning vomiting, then you know that most likely the patient is having withdrawal symptoms. Okay, so this is again another point towards alcohol. Okay, so the patient actually have alcohol liver disease. So to make it safe, you can mention alcohol related liver disease, or if you're very sure the liver function is very deranged, you want to mention alcoholic hepatitis is not wrong. Okay, another thing is the patient BMI is overweight. So you should also offer the metabolic associated fatty liver disease. Okay.
Okay.
So fatty liver disease is also one of the possibility. Okay. Another thing is because of the alcohol consumption and also the lifestyle, you should also include gallstone disease to be part of your differential, especially in relation to the scenario of bilirubin is also elevated and the GGT is also elevated, about almost like cholestatic kind of jaundice, right? So you should also try to include those cholestatic differentials. And yes, chronic pancreatitis sometimes may have a very vague symptom, but they are generally very thin, not in this patient. And then viral hepatitis, definitely the possibility. So you also want to make sure that when you investigate the patient, it's not enough to mention the liver function test that alone. Because if you're thinking that this patient is having hepatitis, then you should also try to know what is the coagulation factor, what is the VBG, any lactic acidosis, and what is the ammonia level. Okay, you can also do some non-invasive calculation, for example, FIT4, MELD score, Liddy score, especially in particular you're thinking of alcohol hepatitis. Okay, you know what's the rationale of doing the Liddy score?
Doctor, actually, I'm not sure.
Not sure. Like actually, before doing the Liddy score, we should do the MELD score. MELD score will tell you whether patient has a very severe form of hepatitis. If the MELD score is very high, then it is not a good prognosis. Okay. Then let's say the MELD score is actually very high. So in alcoholic hepatitis, we can actually give a trial of prednisolone steroid, okay, for 1 week. So for further assessment to reduce the inflammation, and then after that we assess again with Liddy score whether patient improve or not with the prednisolone. If let's say improve, then we can continue for some time. And then if let's say if prednisolone trial still not working, MELD score is still increasing, patient liver condition getting worse, then you really need to talk about liver transplant, bridging therapy, and all those things. But basically, generally, I will go through the general algorithm for the EASL for alcoholic hepatitis. But general thing still just mention the simple thing like what you have mentioned, infective screening. You should also mention about fasting lipid profile if you're thinking of muffle D, and then ultrasound
Okay.
abdomen, TFT. And mileage is also important because of vomiting, right? Many times already
Yep.
the patient vomited, so it's also
Yep.
important. And then because of alcohol-associated nutritional deficiency, B12 folate is also important. And then because patient intermittently taking paracetamol, you're not sure whether the history is viable or not, you may want to consider to take a TDM as well to make sure the patient TDM level is not high. And then female patient, especially, you must make sure that she's not pregnant. Okay. So sometimes alcohol I mean, regardless of what presentation, what scenario, it's always good to think that whether you need to check the patient whether the patient is pregnant or not. Okay. As the management can be different, and also the types of management that we determine is also decided by this. And then talk screen, if let's say suspicious of whether there's any substance use, basically that's general, that's it lah. And then you admit for observation because patient vital sign got hypertension, tachycardia, you advise for reduction, watch out for withdrawal, and then work out and then optimize the mode, everything as you mentioned lah, huh? But don't
Okay.
forget about lifestyle and also timing lah. Alcohol must remember timing, okay? Timing
Okay.
is something that you want to mention early if you don't have time. Consider timing supplementation, watch out for withdrawal, and then referral to all the respective colleagues, and then manage the patient mode, symptom, and all those things lah, okay? So I think the concern part I only ask you one question, not enough time. You can see that you need to really
Yeah.
give the surrogate to ask question, lah, huh?
True.
Don't keep saying and explaining, but give time for the surrogate to ask. Do I need admission? Then you will say yes. But if you say yes, admission, then I will say that I actually refuse. I don't want to be admitted. Got two children waiting for me at home, doctor. I want to go back. Then sometimes this kind of consult scenario can, one of the concern can bring you to kind of like com skill type of counseling as well. You may need to
Yeah.
spend a bit time. So that's why you need to give some time for the concern. Okay. And then what's the
Okay.
next step? Is this cancer? I suppose you know how to answer. Lah, huh? Okay. So this is just a very simple algorithm lah for alcoholic hepatitis. Let's say this is a scenario alcoholic hepatitis. So history of heavy alcohol with recent onset of jaundice. Let's say, I mean, if dependence, we'll still treat as dependence, but if an acute situation, you need to calculate the score. There's something called modified manual discrimination function, or you can use a MELD score, or you can use the GAHS, Global Alcohol Habit. Okay, I don't need to mention all these prognostic score, but just in short, you can just mention that we'll calculate the MELD score or some other prognostic scoring to know the severity. Let's say it's actually severe, you may consider a course of prednisolone and reassess the utility score. Utility score is actually low, meaning responded to prednisolone, you may consider to continue prednisolone for about 1 month. If the score is high, then there's no role to continue prednisolone, and you should actually refer early referral to the patient to the transplant center, and then to consider some other therapy, like for example GCSF, for example some plasma exchange, all those things, which I think is beyond the topic of discussion. Usually examiner will not ask so detailed, but just to know the general management for alcoholic hepatitis. Okay, so any question, Dr. Tan?
No, thank you so much, doctor.
Yeah, thank you. So you must practice more. My advice for you is you are quite fluent. It's just that you need to be a bit more concise. Try to avoid long words or even long sentence or explanation. Make it very simple so that it's easy to understand and also easy to convey your message as well. Because if you got too many things to mention, then a lot of main points may not have time to convey, and examiner may think that you miss certain things. Okay.
I see. Definitely.
Alright.
Thank you so much
Okay,
for
all
your
right, no
comment.
problem.
Thank you.
Okay, thank you, thank you. Okay, so we'll proceed with the third candidate. I think it's Dr. Chiu, right?
Yes, yes,
Hi, hi. Can you hear me?
yes, I can hear you.
Okay, okay. So, you are ready to start?
Yes.
Okay, so I will give you 4 minutes, for preparation, and you will start now. just for housekeeping announcement. So those that actually going for exam quite soon, don't want to waste your time. So whoever want to actually leave the conversation and listen to the recording later is totally fine. Yeah. So the priority is just for those who are preparing as an active candidate for today. Okay. Okay, time's up, Dr. Chiu. This is Madam Pavitra. So please start.
Hi, good afternoon. Am I speaking to Madam Pavitra?
Yeah, I am Pavitra.
Hi, I'm Dr. Chiu. I'm the doctor in the medical unit today. So I received a letters saying that you are having this hand numbness for the past 3 months. Would you mind to tell me more?
Yeah, doctor, I've been having numbness over my both hands for almost 3 months now. So it comes like intermittently. Sometimes actually works. It get worse when I do activities like typing. When I try to rest, I feel my numbness actually getting better, doctor.
All right, I'm sorry to hear about that. I hope that by the end of this discussion, I can help you better. So, can I ask, did it happen suddenly or gradually?
It happens like on and off.
Okay. Okay. Where is exactly the location of the numbness?
I feel over, especially over my tips, all my fingertips, as well as my wrist as well, my whole hand actually.
Okay. Do you mean that it's up to your shoulder or
No, no,
just
no,
only
no.
up to the wrist?
It is up to my both wrists. Both
All right.
wrists. Yeah.
Okay. Okay. So is it like the pain? Is it going to anywhere of the body?
No, no, no.
Okay. Do you feel weakness over your arms and do you have any weakness over the arms?
No.
Okay. Um. So do Okay. How does it affect your just now you mentioned that you are having the pain while typing. Any other activity that is making it worse?
Yeah, generally if I carry objects or do any activities that involve my hand, I feel like it get worse.
Okay. Okay. Do you have any do you feel tiredness?
Tiredness. I think I sometimes feel a bit tired, especially towards if I do more activities, if I exert myself, I do feel a bit tired, doctor.
Okay. You feel tired over the hands or generally the whole?
Generally.
Do you feel tired at the end of the day?
No, not really. It's not specific.
Okay. Do you have any lumps and bumps?
Not that I'm aware.
Do you have any fever?
Fever, not really, doctor.
How's your appetite?
Yeah, my appetite hasn't really changed much.
Okay. How is your weight? Any change in your weight?
Yeah, speaking about weight, I think I'm getting more slimmer nowadays. For the past 2 months, I think I lost about 3 kilos.
Was it intentional?
Not really. I didn't control my diet or anything.
Okay. Do you have any preference to hot weather or cold weather?
No,
Is there any abnormal shakiness over your hands?
no,
Do you feel dizzy when standing from a sitting position?
no,
Do you have any rash or spot or pigmentation over your hands or body?
no,
Um, do you have any rash when exposed to sun?
no,
Any sore in your mouth?
no,
Any red eye or gritty sensation over the eyes?
no,
Any dry eye or dry mouth?
no,
Do you have any joint pain?
no.
Okay. Do you have the is your symptom get worse when you are sleeping at night that make you wake up from sleep?
Oh, no, no.
Okay. So madam, can you tell me, do you have any headache?
No,
Do you have any unsteadiness when walking?
no,
Do you have any problem with speaking, talking?
no,
Okay. Do you have any past medical condition that's diagnosed before?
The only medical problem I have was a high blood pressure when my GP diagnosed me 3 years ago. I'm on amlodipine and metoprolol.
Okay, are you compliant to this medication?
Yeah, I was compliant. Previously, the doctor did change my medication. Initially, I was on a medication called perindopril, but subsequently I developed some kidney injury according to the doctor. That's why it was stopped and then it was changed to amlodipine. And now my blood pressure is okay with amlo and also the metoprolol.
Okay, sure. Besides this medication, are you taking other over-the-counter medication?
No,
Okay. So do you take any uh, traditional medication or herbs?
no.
Okay. May I know, are you taking any birth control pill?
You mean hormone pills? No.
Yeah, hormone pill. Okay. When is your how is your period like?
My period has been regular.
All right. May I know when was your last menses?
My last message was 2 weeks ago.
Okay. Can I ask, are you married?
Yes, I'm married, but I got no children.
Okay. Is there any problem with any history of miscarriage before?
Oh, no, no, no.
Okay. May I know what do you do for a living?
I work as a typist.
Okay. Um, so I'm going to ask about some personal question. I hope you don't mind. I do ask to all my patients. Um, do you smoke?
No,
And what about alcohol?
no, no, I don't think.
Okay. What do you have any have you tried any party drugs or any ear piercing or tattooing in the past?
No, no, no,
And do you have any unsafe intimate relationship before?
no.
Okay. Do you have any traveling history before the onset of these symptoms? Hello. 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 Can you hear me? Hello. Can you hear me?
Hello, can you hear me?
Yeah, I can hear you now.
Yeah, sorry for that. I think got some technical issue. Yeah, sorry, you're saying?
Do you have any traveling history prior to the onset of this symptom?
No.
Okay. Uh, have anyone noticed that you are more pale or more yellow than before?
No.
What about your appearance, general appearance? Have anyone commented on it?
No, not really.
Right. Do you have any sore in your private parts?
No.
Okay. Any recent procedure done, for example, injection or any operation done before?
No.
Okay. Is there any episode of like you injured your hand by that you are unable to feel the temperature of the kettle and you burn your hand?
Oh, no.
Okay. All right. I would like to examine the patient.
Okay.
I would like to do the sensation test, pinprick sensation over the both palms. Is there to confirm peripheral neuropathy?
Both sensation is intact.
Okay. What about the proprioception?
Sensation is also intact.
And I would like to perform the Tiner sign.
As you perform a tinea sign, patient no complaint of any numbness. Both wrists.
Okay. Can I check the power of the hand grip and also the wrist?
So when you check the hand grip, it's very good hand grip, and then the wrist, both flexion and extension is good. 5 out of 5.
Okay. Is there any nail changes?
No. The nail
Any
as you can see is on artificial nails, but no she say got no other issue. The nails.
how is the range of movement of both wrist joint and also the hands?
Range of motion is normal, is intact.
Uh, any sign like swollen or tender joint?
No, there's no tender joint.
Okay, and I'll proceed to examine the eye. Is there any pallor, any jaundice?
No pallor, no jaundice.
Okay, and I will also examine the neck. Any lymphadenopathy?
No lip adenopathy.
Any thyroid swelling?
No thyroid swelling.
And how about is there um, any rashes over the face or over the bilateral hands?
No rash over the face or hand.
Okay. I would like to check bedside sugar and yeah, what's the sugar level?
Sugar level is normal.
Okay. I would like to check the upper limb. Is there any proximal myopathy?
No proximal myopathy.
Is the patient Cushingoid appearance or acromegaly appearance?
No Cushingoid or acromegaly features.
Okay. And how is the reflexes over the bilateral upper limb?
The reflex is normal.
Okay. All right. Okay. I would like to proceed to examine the abdomen. Abdomen. Is there any abdomen tenderness?
No,
Any
abdomen is
hepatosplenomegaly?
soft. Abdomen is soft, non-tender. No organomegaly.
Okay. And is there any alopecia? Any alopecia?
No alopecia.
Any oral ulcer?
No oral ulcer.
Okay. Is there any rash over the palm or sole?
No.
Okay. So
2 minutes left.
sir, sorry, madam, can I ask, do you have any concern?
Yeah, doctor. What do I have, doctor? Do I need to be admitted?
Um, for now, you do not need to be admitted, as we can investigate you as a outpatient. So I believe that you are having symptoms related to the nerve, um, which we need to do further testing.
Oh, but what causes the nerve problem, doctor?
Probably you are having some some disease that is attacking your defense system.
Oh, okay. Can this be cancer, doctor?
At this point of time, we it still be possible as you are having some uh, changes in your weight. We will make sure that we will investigate you on this.
Oh, okay, doctor. Then can I get pregnant later on?
Um, yeah. You may until we find the cause, and if the condition is treatable and it's controllable, you may get pregnant later.
Okay. Is this a curable disease, doctor?
If the if it depends on the underlying cause, exact cause of the condition. If uh it is a controllable disease, it is not curable.
Oh, okay. All right. Okay. Then can this be a family disease, doctor?
As there's no any sorry, I didn't manage to ask you regarding your family history. If there's no family history of the similar symptom, I do not believe it's running in the family.
Okay, all right. Time's up. So, Dr. Chu, would you mind to tell me what is your differential diagnosis and your most likely diagnosis for this patient?
Mm, my differential for this patient, peripheral neuropathy,
Bilateral?
bilateral peripheral neuropathy.
Okay. But what is the underlying etiology?
Mm, yeah, I think I didn't get the exact underlying etiology.
Okay, then do you have any differential diagnosis?
Uh, Initially, I was thinking maybe it's a carpal tunnel syndrome or mononeuritis multiplex.
Okay.
Yeah,
Any other differential?
drug induced or probably
Okay.
paraneoplastic peripheral neuropathy.
Okay. Okay, all right. Any more common differential diagnosis? Patient is a typist.
Oh yeah, osteoarthritis.
Osteoarthritis. Okay.
Yeah, yeah, that is causing, I mean, prolonged usage of the joint, causing the degeneration.
Okay. Other than that, is there any like other looking at the patient presentation, and how do you notice anything unusual from the vital sign?
The diastolic is high,
Okay.
diastolic pressure.
Patient has high blood pressure, right? Hypertension, right?
Yeah.
And then do you think it's normal for her to have hypertension?
Mm, if it is well controlled, it should be normal. So this is yeah, a bit unusual.
Unusual as in?
Um, the diastolic pressure is high.
Okay, we know that the patient have hypertensive, but then the in relation to patient age and presentation, what are the things that you may want to suspect for?
Young hypertension.
Okay,
Mm.
and if you think the patient has young hypertension, what are the possible causes of young hypertension for her to have this presentation?
Mm. Thyrotoxicosis, SCES. She's having weight loss. She's having weight loss, thyrotoxicosis, and
It's okay.
mm,
How will you investigate this patient?
okay. I would for to confirm my diagnosis, I would need to um do the nerve conduction study to see any problem with the um demyelination or axonal neuropathy. And also I would send blood investigation for fasting sugar, fasting lipid, and HbA1c to exclude diabetes.
Mm-hmm.
And I would also check thyroid function test, urine FEME, and also morning 24-hour urine cortisol level to exclude Cushing syndrome that can cause hypertension. And I would send renal profile to look for hypokalemia. If in the case of hypokalemia, I would also suspect Conn's syndrome, and I would make sure if it's and also VBG to look for any metabolic alkalosis.
Mm-hmm. How will you manage the patient in terms of the numbness?
Um, for for the management, I would involve occupational therapists and physiotherapists for hand exercise, and also for any spleen, and for home and work modification to maintain the patient function.
Mm. Okay, time's
For
up. Okay, time's up. Okay, Dr. Chiu. Have you encountered any scenario of hand numbness before?
I encounter is unilateral hand numbness.
Okay, bilateral hand numbness never encountered yet.
Mm.
Okay, then let's say the one that you encounter unilateral hand numbness, what was the differential?
There was acute stroke with spinal thalamic involvement.
Okay, all
Mm.
right. It can be due to lacuna or total anterior circulation, right?
Yeah.
Okay, so you have excluded stroke in this patient, but this is a bilateral hand numbness up to wrist. Okay, and what is your idea when you see the vital sign? Let's see this. What is your idea when you see this outside the scenario?
Actually, I never, it didn't strike my mind of have young hypertension.
Mm.
Yeah.
So when you prepare this scenario, the first thing you notice is actually, yes, the presentation of hand numbness, but take a step back and look at the patient file. 42 years old with a high blood pressure, right? You know the diastolic is high, it's memang high lah, it's memang hypertension until proved otherwise lah. But this is a young hypertension. So young hypertension with this hand numbness will strike you off a few things, you know. So there's a few things that you really need to make sure you excluded. And because of this hand numbness, your approach is not just hand numbness per se, is to make use of all the clues to help you to get into the diagnosis. And how do you know when the hand numbness is like so non-specific, right? So you need the second clue, which is a young hypertension, and patient got weight loss. Okay, patient got weight loss, right? However, the appetite is quite normal. So that gives you a few differential diagnoses down the line for you to exclude already. So the problem with you is actually I notice you don't know which direction you are heading, and you are out of differential. That's why you just ask the usual history question. You just screen for everything, but everything also normal, then you're stuck. Am I right?
Yeah.
Yeah. Are you going for exam soon?
Yeah.
Yeah. So if you go for exam soon, this is perhaps a scenario that you must know. So let's say this is a hand numbness, bilateral hand numbness lah. You didn't ask me about feet numbness, right? I didn't recall you asked me whether my foot got numbness or not.
Yeah.
So you must ask about other parts of the body whether any numbness lah. You did ask about is it whole hand or the whole is the whole limb or is the hand only? So whether or not you need to exclude. Okay, hand numbness, there's a few differential diagnosis per se. The commonest being hypocalcemia. Okay, hypocalcemia. That's the first thing you must write in your paper, hypocalcemia. Second thing is it can be hypokalemia as well. And hypokalemia with young hypertension, you are thinking more to Conn syndrome. Am I right? You're
Yeah.
thinking more to, can this be some form of primary hyperaldosteronism? Therefore, you also want to exclude any proximal myopathy. So you ask patient got any weakness. That's not wrong at all because you're thinking of that hypokalemia possible. Okay, what are other differential diagnoses of hand numbness do you know? Other than these two?
You mean for bilateral?
Yeah.
Mm.
Just hand only lah. I mean the arm, the forearm is normal, but only hand numbness.
Peripheral neuropathy?
Can be peripheral neuropathy, but not very common to present as hand numbness per se lah. No, patient must have a lot of comorbid like diabetes uncontrolled, all those things very obvious, right? So you must remember to all the obvious thing first. Carpal tunnel syndrome. Patient can have bilateral carpal tunnel syndrome. Okay, so you must write the carpal tunnel syndrome part of your differential diagnosis because writing that will actually give you, can this be some form of secondary causes of carpal tunnel syndrome? What can it be? It can be some form of chronic kidney disease causing secondary amyloidosis. It can be due to endocrinal causes like Cushing disease, acromegaly. It can also be due to hypothyroidism. You see, so now and a lot of those actually can cause young hypertension as well. So you have to go by that approach, okay? So other than carpal tunnel, other than hypokalemia, hypocalcemia, what other differential diagnosis for hand numbness? Mm-hmm.
I was thinking drug-induced peripheral neuropathy.
Drug-induced peripheral neuropathy. Okay. But I would say that again, peripheral neuropathy is not common, okay? And if let's say there is a peripheral neuropathy, you need to identify what is the cause. If you cannot identify the cause, it cannot be idiopathic, right? Cannot be suddenly patient have CIDP or something without any muscle wasting or anything, just pure sensory like that. So when you encounter hand numbness, you also need to write a few differential. Can this be some form of Raynaud phenomenon? Does patient have any Raynaud features or not from the history? Because Raynaud patient, if you ask them, they will also have some numbness as well, okay? Because of the vasospasm. And other than hypocalcemia, hypokalemia, carpal tunnel, you must also rule out Takayasu arteritis, okay? Takayasu arteritis presentation can be just hand numbness, okay? And it also present with young hypertension as well, okay? Other than that, can also be some form of leprosy. Leprosy sometimes can be unilateral, sometimes can be bilateral. So leprosy is also important. You ask about any skin problem, okay? Any skin area that a bit numb when you touch, doesn't feel much, and then any change in facial appearance, okay? And then other than that, the remaining two is slightly more to elderly, but another one can occur at any age, which is a thoracic outlet syndrome. Thoracic outlet syndrome can be because of some form of congenital weak compressing of the nerve or some form of any mediastinal compression can present at any age. But the elderly one, usually they can present as what we call a subclavian Steele syndrome. Okay, subclavian Steele syndrome, usually they have some cardiovascular arteriosclerosis. They may have diabetes, may have hypertension, and the age usually elderly, like more than 40, 50 like that. And then they usually also can have a bit of claudication over the hands as well as the arms. And then they will also present with differential pulse volume. And they may also feel dizzy if they change their hand movement. because of the still phenomenon. So all these are the differential diagnosis for hand numbness per se. If you didn't write those things down to your list, you will definitely never get a diagnosis because the question you need to ask is quite specific. Same goes to examination, okay? And with the young hypertension overlapping this scenario, you are really trying your hard to rule out what are the etiologies to explain both, okay? So that's why this case you really cannot score. Unfortunately, you cannot do the scenario well, okay? So this is actually a case of Takayasu arteritis. Have you heard about this condition before?
Yes, yes.
Yeah, I know it's not common in real life practice, but it is a common in PACES exam. It's one of the PACES favorite to know, okay? Because what happened is that once you know Takayasu arteritis can only present in few ways only. It can present with neck pain, in which this patient actually have neck pain. Because you didn't screen for full rheumatological symptom, you therefore did not elicit that the patient actually have neck pain, okay? And then the scenario can present with neck pain, can present with hand numbness, can present with young hypertension, okay? And the clue is actually how to diagnose is by doing a differential blood pressure and differential pulse volume. Examine for both pulse volume, look for diminished pulse volume over one side and differential blood pressure over either side of the arms. Okay? So this is very important because if you know this is Takayasu, you know the examination, you need to feel for all the pulses, including the carotid pulse, auscultate, look for whether there's any carotid bruit to suggest stenosis. And then you also need to check the renal bruit for any renal artery stenosis. This patient, the scenario actually, I make it a bit easier. I told you that the patient 3 years ago presented with hypertension in GP. They started Arindopil, right?
Yes.
And the patient have AKI, right? And therefore was switched to amlodipine with another one is what? I cannot remember.
Metapolo.
Metapolo, yeah, beta blocker. So that gives you a clue that maybe patient have bilateral renal artery stenosis. That's why the patient have AKI. Okay. So if you're able to link all this information together, you will think that the patient can be some form of vasculitis, can be Takayasu arteritis. And when you attempt to auscultate for the abdomen, you will appreciate that there will be renal bruit. Okay. So this is I would agree that this is not an easy case, but at the same time, it is not too difficult. You just need to have your approach. If you don't have your approach, it is very difficult because you will not able to get a diagnosis by just asking what you usually do, like what you have attempted just now. Okay, so let's go through the scenario. So you can see that the hand numbness is intermittent, and at the same time, patient also got constitutional symptom. This is a warning sign. If you think that this is peripheral neuropathy, usually they don't really have this kind of constitutional symptom. Yes, you're thinking about paraneoplastic peripheral neuropathy, which is not common. Is it very rare? Okay, so you need to think of something that can link everything together. So weight loss, unintentional neck pain as well. Actually, if you ask me, I will say that on prolonged walking, I do have a leg pain, and on prolonged usage of my hand, I do have a bit of hand pain as well. Okay, but because you didn't ask that specific question, you will not get the answer. Okay, and definitely you need to screen for all the autoimmune symptoms to exclude as particularly Raynaud phenomenon. You also need to exclude hypocalcemia symptom. So hypocalcemia, if you encounter any hypocalcemia in exam, you need to ask about two complications, which is any fitting episode, any racing or pacing of heartbeat to suggest palpitation or arrhythmia, okay, because of the prolonged QTC. So that's why you need to ask about these two. When you ask about hypocalcemia, remember all that. And numbness or hypocalcemia is not just the bilateral hand, right? It's also asked about any facial numbness, okay? Any facial numbness, any hand numbness, any numbness over your feet, okay? And then leprosy, you're asking about any skin problem and any sick contact, okay? Another thing is thoracic outlet. Basically, you ask about any recent or previous injury to the chest or any history of any abnormality when you are born, any birth defect or anything. For example, simple one, okay? But the key is really young hypertension. If you fail to realize that this patient has a young hypertension, in fact, if you prepare this scenario outside, you are expecting to ask that, have the doctor before tell you what might be the cause of this? Have the GP actually work out further, refer you for further workout, things like that? You need to ask because young hypertension is abnormal. We cannot ignore a young hypertension, just like in real life situation. I remember I've got one patient in ophthalmo ward refer me for young hypertension because I was taking endocrine referral. because nephrology, cardiology, they don't want to see the patient. Somehow I have to see the patient, but there's no other features to suggest endocrinal causes. So I asked for every workup. And one of the workup I asked is actually ultrasound renal, ultrasound KUB with renal doctor. And that result, few weeks later, turned back as renal artery stenosis. However, to my surprise, I remember I really examined her. She got no renal bruit. Sometimes not all renal artery stenosis may have bruit. It depends on the degree of severity. So again, bring to the fact that we should not omit a young hypertension. Okay, once you encounter a young hypertension, you need to really look hard what is the cause. And this patient, you did ask about all the gynae history. I'm happy. And then social types, this is also to give a hint that can this be carpal tunnel syndrome because of the occupational mechanical type of exposure of the occupation. Okay, so you also need to, given enough time, you need to explore that how does the patient's symptom affect the patient quality of life. And in this regard, the patient, if you ask, patient will say that because of the job nature, I really feel cannot work well, I have to stop typing. I really have to really rest for a while. Only I can continue this. You see, so it's important for us to ask all this. Okay, and the examination is really about noticing the blood pressure to be high to begin with, and mention that to the examiner. So I would say a smart way to mention is that when the examiner, okay, when you ask to examine the patient, right, looking at the patient as a whole, you want to mention that, okay, sir, I noticed that the blood pressure in the scenario was high in the outside. I would like to repeat the blood pressure. Is it okay? Then examiner sometimes will say, no, no need, it's okay, just follow. Then you will say, I want to measure a differential blood pressure, check for 4 limbs. Oh, sorry, got typo, should be 4 limb, LIMB, 4 limb BP to look for any differential blood pressure. Anything more than 20 is already significant for systolic. So examine for the 4 limb pulses as well to look for any asymmetric pulse. And then, yes, you need to examine the hand, look for any joint in which you did. Look for any deformity, any subcutaneous nodule, gout, or whatever, rheumatoid nodule, to look for any rheumatological causes, deformity. Essentially, Raynaud phenomenon sometimes may not be able to get, even if patient has, depends on doing the examination. Okay, and then inspect for any wasting, check for sensation, perform a Tinel sign, in which all you did. Okay, and you also need to rule out leprosy. You want to check for whether there's any thickened nerve and also hypopigmented patch. This is just a quick screen through. Doesn't think that you need to check the whole body in detail. But this is just something that you need to think through because it's in your differential. And then proceeding further, you should check the neck for carotid bruit, any scar, any neck swelling. You did check about neck swelling because you're thinking of possibility of thyroid disease like goiter. Abdomen, you also want to palpate and also check for ballot for any kidney suppressor or any bilateral renal bruits. And then following after, you should check for urine FEME and fundoscopy because patients have young hypertension again. So you see, to offer to check for urine dipstick and fundo is something most people will forget to mention, but this will, and this actually sometimes not in the exam calibration sheet, but it will actually, to me, it will give a good impression to the examiner that you are thinking of it. You're thinking of assessing the complication of hypertension, for example, assessing the complication of diabetes. So to me, it's always like a natural response when after I finish my examination, before talking to patient, explaining to patient, I will tell that I want to check for urine dipstick and fundoscopy. Okay, it makes you a more matured kind of physician as well in the exam. Okay, so again, the differential diagnosis is actually Takayasu because of the limb claudication, young hypertension, asymmetric pulse. If you ask me, check the blood pressure, everything, there is discrepancy, and there's also a renal bruit as well as the carotid bruit. Okay, so differential diagnosis for this scenario definitely, as what we go through, carpal tunnel syndrome. Also want to do out what are the causes of carpal tunnel syndrome. So Cushing, you need to rule out. If let's say, I mean, I didn't give any good photo but just assume that this is a normal patient that is not obese, not Cushingnoid. Therefore, it makes it less likely. Can it be hyperthyroid? Sometimes possible, even without a goiter. Okay, not all toxic nodule, thyroid nodule is actually palpable. So, but you can also offer sometimes because of the weight loss, with the appetite is remain almost good or normal. And then connective tissue is hypocalcemia, thoracic outlet is also part of your differential, but less is down the list. Okay, if you know that this is a Takayasu, how do you work out? It's inflammatory markers, leukocytosis, check for RP, any derangement because of the renal artery stenosis, ESR, CRP for inflammatory markers, thyroid function test, yes. Hypocalcemia, because you need to check, make sure it's not dealing with hypocalcemia. And then autoimmune screening like ANCA, ENA. And this kind of patient, you should do an echo, carotid renal ultrasound Doppler, okay? And then also a CTA, MRA as well, especially for in relationship to Takayasu, because you want to look for any what we call as bed, venous vascular bedding or narrowing or occlusion, okay? If let's say the CT MRA is normal, but the clinical suspicion is there, then by right, the gold standard is digital subtraction angiography, which is a DSA, okay? So let's say this two imaging is normal, then you should proceed with DSA. Management is really about MTT approach, refer to rheumato, consider steroid initiation, okay? There's also a disease modifying therapy, which is a steroid sparing agent. And then, as importantly, to address the patient concern regarding the pregnancy, you should tell the patient that we need to work out and identify what are the disease that we are dealing with, because certain disease need to make sure that it's in control state first before we talk about pregnancy. Unfortunately, we need to iron out everything after we work out. Don't have to promise the patient, yes, you can get pregnant later on after this thing is settled, because some certain things, certain disease may not be fit. Patient may not be fit enough to go through a pregnancy. And then another thing is that the antihypertensive, because with this compliance to these two medication, the blood pressure is also high. Okay, again, point to the fact that you need to optimize the antihypertensive, and you may also need to issue a card saying that the patient may have a renal artery stenosis, therefore should avoid a RAS blockage. In case next time seeing another GP, the patient start back on the ACE or ARB, then it will be very harmful for the patient. Okay, so to address all the other question, I think you address most. So any question from you, Chiu?
Yeah, I think yeah, no further question.
No further question, but I got a lot of question for you. Okay, so do you know how to approach young hypertension?
Yeah. Young hypertension, basically we need to screen for secondary hypertension.
What is your approach in exam?
I would screen from top to bottom.
Top to bottom. But in exam, you have to imagine the patient top to bottom is also a bit of time, right? So do you have my notes before this?
Yeah.
You have my notes, right?
Yeah.
You have my notes with you?
Yes.
Yeah. Can you flip to the young hypertension page, in which I also cannot remember what was the page? I think it's around 98. Page 98. Okay.
Yeah.
Do you manage to see the table?
The weight loss, weight gain.
Yeah. So actually, just to bring through, I mean, it's the same table, like for those that don't have my note, it's okay. So it's the same table that I feel is very useful for exam purpose, as well as for real life as well. I tend to think in this approach as well, because it's a very convenient approach. If you go by weight, then most of the time it's easy for you to think through the differential. Because in exam, if you go to top to bottom, A to Z, or even for vitamin or vindicate, all those things, it will take a lot of time, because it's not something that we actually mentally rehearse day in, day out. So it's always good to make sure that we go by a simpler way. This approach I learned from tutor, Dr. Hassan. I think it's very practical. In fact, most of the scenario that looks complicated, I tend to divide by weight, and seems more approachable and also easy to do. So for weight gain, it's usually more of the endocrine causes like acromegaly, Cushing, hypothyroid, obesity, also part of the endocrine, right? The remaining one is like OSA, pregnancy is something we need to include. Okay, for weight loss, it's very specific. So it can be endocrine, can be rheumato, or can be vasculitis. These three possibility. That's why this patient has a young hypertension with weight loss. Yes, hypothyroid is one of the possibility in relation to numbness, can be due to carpal tunnel. Yes, pheochromocytoma, possible as well, but you should actually also screen for whether there's any episodic flushing, episodic sweating, and also racing of heartbeat, as well as very, very uncontrolled blood pressure. Okay, and then rheumato, you try your best to screen through all the rheumatological symptoms, but also remember to ask about neck pain and back pain. Sometimes the rheumato symptom may not have a full-blown kind of manifestation, can be very patchy, and vasculitis is definitely important. So for this scenario, if you go by this approach, you will able to get the diagnosis, okay? And if it's a weight static, I mean, not much change of weight, then you are thinking more to GN causes, renal causes like ADPKD, renal artery stenosis, GN, Alports, or even like neurocutaneous stigmata kind of diseases like tuberous sclerosis, neurofibromatosis, or one hip now. Not very common, but something keep me at the back of our mind. Con syndrome, yes, Con syndrome also important. We need to screen for Con syndrome. Coarctation aorta fail. Basically, the remaining lower bottom is actually can be anything overlapping. Okay, but the drugs one usually also important, especially patient with young hypertension need to ask about their caffeine, whether patient is a regular coffee drinker, and then whether patient taking any illicit drug like cocaine. Okay, and if the patient has any hormonal pills, we know that long-term use of hormonal pills like OCP may actually cause hypertension as well. So all those things we need to really screen through. Okay, so this is just a Takayasu arteritis classification criteria. Like the one in my notes, I used back the old criteria ACR one because that one that criteria a lot of examiners are more familiar. Like, a lot of examiners are not familiar with this new classification, but I'm quite aware that when the new exam came up with new format, they will try to use new stuff as well. So it's also good if we can remember a bit, but not the score exactly. What are the components that they usually do for to classify the Takayasu arteritis. So the classification criteria, if you realize the compared to the old criteria, compared to the 1990s criteria by ACR, used to be age less than 40 years old, very young presentation. But the new criteria actually adjust the cutoff from 40 to 60. Reason is being they found out that a lot of patients they may not present with any symptom at all, and therefore those more than 40 may miss a diagnosis of Takayasu. That's why they further bring up the threshold to be 60 years old. Okay, less than 60. And then what are the additional criteria? Female has a higher risk. Okay, got any symptom to suggest claudication over the limbs, and then let's say got any chest pain, and whether there's any vascular bleed from the examination, reduced pulse as well as the differential blood pressure. Carotid artery abnormality will based on the imaging criteria lah, basically. To me, it's not important to remember. The important thing is to identify all these possible components to help you to make a diagnosis to suggest that this patient may have a Takayasu arteritis. Okay, so if a patient, if you really want to use this classification criteria, this patient definitely more than 5. Okay, more than 5. Bear in mind that classification criteria is not diagnostic criteria. Same goes to the ACR criteria. It's actually for classification criteria. In rheumato, they don't really have a diagnostic criteria. Classification criteria, the difference is that it helps them to select the patient for clinical trials. Okay, but in rheumato, generally not much of diagnostic criteria they use, but we always use the classification criteria to guide us. Okay, so this will be Takayasu arteritis lah. And another approach from this scenario is the hand numbness part. So we have to go through all the possibility of the hand numbness. Okay, it's only about 6 or 7 causes of hand numbness. So if you go through by that and then you overlap with your young hypertensive approach, then you should be able to get a diagnosis. Okay, certain condition like for example, a common scenario will be like for example, neurofibromatosis came in with young hypertension, very expected scenario lah. So the causes can be due to a few things. It can be due to pheochromocytoma in relation to neurofibromatosis. It can be due to renal artery stenosis. It can also be due to coarctation aorta as well. So these 3 possibilities lah. But generally, the idea is to really have your own approach. In this basis exam, the rule of the game is if you have a good approach, then you should have no problem to get a diagnosis. The remaining one is just to fine-tune, to make your investigation, for example, to make a management concise as well as meaningful, as well as more matured. Okay, so that will be it. Okay, Chiu.
Okay.
I hope you learned something. I know Takayasu, certain people will think that it's rare, but many center, especially local center, this Takayasu had come out quite a few times already. So I wouldn't consider that as a rare when it comes out more than once. Okay, so we need to keep an eye for this kind of scenario as well. Okay, so last candidate will be Dr. Abhi. Are you there?
Yes, Dr. I'm here.
Yeah. Sorry for waiting. I know you're from
That's
Nepal.
okay.
Okay, so you're ready to prepare the scenario. 4 minutes.
Yep.
Okay, so I will start the timer now.
Sorry, Dr. Jimmy, can I ask a question?
Yeah, sure.
For Takayasu arthritis, just like you mentioned, neck pain, hand numbness, and other features is
Young hypertension.
Oh, okay.
It's just a high blood pressure without anything, can be very asymptomatic. But when you ask, may have a bit of limbs claudication, okay? And only by, if you're asking to check for differential blood pressure and also the feel for the pulse, uh, volume for all the pulses, then only then you will get, and also the breath. So that's the trick for this diagnosis. It's not easy to get a diagnosis, even if you ask for a very comprehensive systemic review. So therefore, the examination is it really the clue, no?
Okay, thank you.
सेभेन्टी फाइभ वर्षको मान्छे टायर्डनेस एन्ड लेथार्जी 2 महिनादेखि सोडियम 120 टायर्ड एन्ड लेथार्जी त हाइपोनेट्रिमिया त भइहाल्यो अब हाइपोनेट्रिमिया किन भयो होला के यसलाई एसआइएडिएच भयो कि होइन बडी ट्युमर हो कि
Okay, time's up. Dr. Aki, are you there?
यस डक्टर
Okay, so we will start the timer. This is Mr. Smith.
ओके
Oh, sorry, this is Mr. Jim.
Jameson. Hello, my name is Dr. Rabi. I'm the doctor in this general medication outpatient clinic. May I confirm if this is Mr. James, next of kin of Mr. Smith, 75 years of old
Yeah,
age?
yeah. I am James. I am the son of Mr. Smith.
Okay, how may I address you, sir, today?
Yeah, Mr. Smith
Yeah.
is beside me.
Yeah.
He's quite okay at the moment.
Okay, all right. So I understand that Mr. Smith presented with the complaint of tiredness and lethargy, right?
Yeah, yeah.
Can you tell me more about it, Mr.
Yeah,
James?
doctor. I noticed that my father has been not in his usual self for the past 2 months. So 2 months ago he was still okay until I realized that he's gradually become weak for the whole body, and then he also feel easily tired. He doesn't really attend to us, as in he doesn't really speak a lot to us like usually. He had
Okay.
also very poor concentration. When we talk to him, he is like a bit within himself. He is
Mm.
not conversational. We are very concerned, doctor.
Okay, Mr. James, I'm really sorry about your father's health, but hopefully by the end of this conversation, I will be able to help your father. All
Okay.
right. So, Mr. James, can you tell me like what sort of time he feels more tiredness in like in the early morning or throughout the day?
I feel generally for the day and night also he feel very tired.
Mm. Is he tired more during some work, some activity, or just tired generally,
In general, I think.
in generally? And you also said he's quite lethargic.
Yeah, tired.
And does that mean that he sleeps most of the day and
Yeah,
night?
he sleep longer than before.
Longer.
He also take a lot of small frequent naps in the morning as
Frequent.
also afternoon. Yeah.
I see. And has he mentioned any other problems like you feeling sick, throwing up?
He not really telling us anything, but from what we
Mm-hmm.
observe,
Mm-hmm.
he have a bit of indigestion problem. He feel like his tummy is a bit discomfort and sometimes has some heartburn kind of sensation, and therefore if he eats a big meal, he will feel a
Okay.
bit discomfort. So we have been trying to cut down his food, try to
Mm-hmm.
just feed him a bit by a bit.
Okay. And is there anything that you've noticed that makes him more tired or makes him better?
We are unaware.
Unaware. Okay. Okay. And so apart from tiredness, how is his appetite
Yeah, his appetite has been really reduced, doctor, for the past two
reduced?
months. Hmm.
He hasn't been eating and drinking well?
No, his appetite has been reduced. He doesn't feel
Okay.
like eating much. Sometimes
Okay.
we have to force him to eat.
Okay. And okay. So that means he's not having any good amount of diet in
Yeah,
diet,
yeah.
right? Yeah,
Yeah.
okay. All right. And can you tell me how is his water works? Like is he having any problem in passing the urine?
No. He still can pass urine. Yeah.
Okay. And can you tell me if he makes a lot of urine volume output or it's as usual?
Mm, not really. We because he's unable to move by himself, so we put him on diapers. So
Diapers.
we didn't change the diapers more than usual. As of we
Okay.
always change about 2 to 3 times, and
Okay.
each time it's not full amount of urine.
But recently you've noticed the urine is volume is less.
In Yeah, I think it's less.
Okay, okay, I see. And okay, and have you noticed any shakiness of his body?
What about the body? Sorry.
Shakiness, like if he is moving his like he's having any
Oh,
shakiness of
shakiness.
his, yeah,
No
no,
shakiness. No shakiness.
no. And has he ever complained of any headaches,
No.
any problem with the vision?
He doesn't seems to complain of it.
Okay, and does he can he manage his daily activity at home? Can he walk around to the washroom?
No. He cannot work for the past 2 months because 2 months ago he was unsteady and he fell down many times already. So we don't allow him to walk. And currently I think he is too weak to walk also. He tried to walk but he cannot.
Okay, I see. Okay, and may I ask if he has any weakness in any part of the body?
Particular parts of the body, no.
Yeah.
It's just
No.
general weakness.
Okay. Okay. And does he have any coughs? Cough?
No.
Any? Has he ever had any vomiting of any blood?
No.
No. Good. Does he complain of any shortness of breath?
No.
Yeah. Has he ever mentioned any chest pain?
No.
Any racing and pacing of the heart?
No.
All right. Has he ever mentioned any tummy pain?
No. I mean, other than feeling
Upset,
other than
heartburn?
feeling discomfort. Yeah.
Okay. And any raised body temperature?
No.
Any night sweat?
No.
And how about his weight?
His weight. I
Yeah.
think he lost about 4 kilos for the past 2 months now.
Okay. Because of low appetite.
Yeah, for 80 kg now it's only 76.
And may I know if he remains low, like how is his mood in general recently?
I think he is a bit slow in response. He's also
Okay,
in terms of his mode, I think he's also a bit conserved. He's not
okay,
speaking up much.
okay. And any joint pain, any rashes you've
No,
noticed? Okay, any
no.
lumps and bumps in the body?
We didn't aware of that. No,
Okay. And have you ever mentioned that he is quite intolerant to any heat or cold?
no.
Okay. Okay. And okay, his motions are fine.
His motion, you mean
Yeah.
whether got any constipation or not?
Yeah.
No,
Yeah.
he was able to pass motion, but a
Okay.
very limited amount because he didn't eat much.
Okay. Was there any episodes that he fainted?
No.
No. Okay. And as anybody has, have you noticed that he looked a bit pale than before?
Mm, we didn't realize that, but for appearance, he almost the same.
Okay. I see. All right. And okay, he's in diaper, right?
Yes, yes.
Okay. So may I ask you questions more, Mr. James, about your father's prior health?
Yeah, sure, sure.
Yeah.
You mean other medical problem? I
Yeah,
think
is he has yeah.
yeah, he have some blood in the stool about 3 years ago, and then
Mm-hmm.
he went to see some surgical doctor. The
Mm-hmm.
doctor say that he has a condition called diverticular disease, in which they have done a scope
Mm-hmm.
and they have removed some polyps lah. Since then, it doesn't really have anything.
Okay, I see. And any medication that he's taking on the regular basis?
Yeah. He was started on this medication called omeprazole,
Mm-hmm.
for the past 2 months already because generally because of the indigestion that he has experiencing.
Okay. So any unprescribed or herbal medication that he's taking?
No,
Any medicine allergies?
no,
Any disease that runs in the family?
not that we aware.
Okay. And by any chance, is does he smoke?
No, he doesn't smoke.
And do he drink alcohol?
He only drink alcohol on social occasion in the past, about four
Okay.
to six units per week.
Okay.
But nowadays
Okay.
he doesn't drink already. Yep.
May I ask if he used to do anything for work as work?
Yeah. He used to work as a school headmaster, but he has
Mhm.
retired lah. And then now it's just sedentary lifestyle.
Yeah, I understand it must be difficult for him to work in these 2 months. Okay. And how about driving?
No. We no longer let him drive.
Yeah, in the past he used to drive then.
Yeah. He used to drive in the past. Correct.
Okay, okay, but not now. That's good. Okay. And is it okay if I examine him?
Yeah. Sure.
Okay. So first I will have a general look of the patient. How is the patient built?
Mm-hmm. Patient
Mm,
is
The
appears thin.
thin built. Okay. And I will start with the hands. If he
Mm-hmm.
has any tremors, any clubbing,
No.
any finger prick marks.
No.
Okay. And I will also check for if the patient has any tachycardia, bradycardia, heart rate
Heart rate is as what written outside. It's normal.
normal. Okay. I will go to the eyes if the patient has any pallor.
No pallor.
Uh, okay. Jaundice.
No jaundice.
Can you please open your mouth? Anything in the mouth?
Okay. The mouth oral hygiene is
Oral hygiene. Yeah.
yeah, oral hygiene is not very good, but there is no oral ulcer.
Okay. Okay. So I want to do the visual acuity of the patient
Visual
first.
acuity of the patient. Examiner say you can skip since patient cannot obey.
Cannot obey. And can patient follow the eye movement commands?
Yeah.
Can do that? Okay. I will check the
Yes.
eye movement. Yeah. Eye
Yeah. When you
movement.
check the
That's
eye
the movement.
motion, patient can follow from
Follow.
left to right,
Any
up to
double
down.
vision?
Patient does not complain of double vision.
Doesn't complain of double vision. Okay. So can I check? I would like to offer the examiner if I can do the fundoscopy for this patient at the end.
Examiner say you can skip.
Okay. All right. So I will check for any neck nodes, any supraclavicular nodes.
When you examine for the lymph nodes, you notice that there is a left supraclavicular lymph nodes palpable,
Okay.
measuring about 2 finger breadth,
Okay.
and
Okay.
it's a firm,
From
non-tender.
okay, I will quickly auscultate the lungs if there is any increase and decrease air entry or any crackles.
The lungs equal breath sound.
Okay. On percussion, any dullness anywhere?
No, no percussion dullness.
No percussion dullness. Okay. I will quickly also auscultate the heart. Any
Mhm.
murmur?
No murmur.
Okay. Then I will go to the abdomen if the patient was complaining of pain abdomen.
Okay.
Any pain anywhere?
No, no
Any
pain.
tenderness? Any liver enlarged, spleen enlarged?
No.
Okay. Then I will go to the lower limb. I will first check for the power of the patient.
Sorry, you want to perform neurological examination
Yes.
for which part of the body?
For lower limbs.
Lower limbs. Okay.
Lower limbs. Yeah, lower limbs. I will check the tone, power,
So we check the
reflexes,
tone. We check the tone is normal. Check the
normal,
power is about 4. Can
for
resist but not strong.
generalized.
Yeah.
Okay. And reflexes, if there's any delayed reflexes,
Reflexes is present but it's not brisk.
so not
Normal.
please.
Both side.
Okay. Both sides. Okay. And a sensory.
2 minutes
Quickly,
left.
I will quickly check this sensation if there is just a sucking glove pattern.
Sensation. Examiner say you can skip.
You can skip. And plantar.
Plantar is downgoing.
Okay. Okay. All right. Thank you, Mr. Smith, for letting me examine. What I will do is I will ask the son if the son has any concerns.
Yeah, doctor. So what's wrong with my father?
So, Mr. James, after examining your father, I think it is related to the one of the, we call it a chemical, one of the, we call it electrolyte, that is sodium, which is very low in your body from the from the reports that I received from your GP. And I think the cause of this could be, I'm sorry to say that, but it could be some, like a mass or a tumor that's inside your father's lung or anywhere in the body. So that could be one of the
Oh,
cause.
you
Yeah.
mean my father have cancer?
I did not mean that, but there may be some possibility of tumor, which may not be cancer as well. Okay. But we have to run further tests in order to confirm. So at the moment, I cannot say it's a cancer.
Okay, doctor. What is the next step for him, doctor?
So we are going to immediately admit him. We are going to do necessary blood investigation for him, and also we'll start him on the fluids. The not the fluids actually. I will we will have to restrict some fluids, and we have to very carefully monitor him, and we have to run some tests.
Okay.
And then
I'm worried, doctor. Do you think that he has dementia?
That's a quite possible, Mr. James, but it is something that will not be this rapidly progressive. It will be a bit, bit slow as compared to what your father has, which is very rapidly, in this past 2 months.
Okay. Okay, time's
Yeah.
up. So,
Yeah.
Dr. Api, would you mind to tell me what is your differential diagnosis and your provisional diagnosis?
My differential diagnosis for this patient will be hyponatremia, secondary to SIADH, likely due to lung malignancy in this patient.
Sorry, why you think this is a SIADH?
So, first, the patient has a reduced urine output. Mm, yeah,
Have you assessed the
and
volume?
yeah, I did ask the patient. The son told me that he had, in the diaper, he had to change the diaper less frequently.
No, as in, have you assessed the volume status of the patient?
Volume status, no, yeah, no. Yeah, I
Hmm.
have to check
So
for
how
that.
will you know whether this is SIADH just based on history alone?
Mm, yeah, I have to check the skin turtle. Yeah.
Okay.
Mm.
So, okay, let's say this is possible SIADH. Okay. So why do you think the pathology is in the lung then? You didn't find any positive signs in the examination.
It could be lung as well as GI because the patient has left supraclavicular lymphadenopathy. So it's probably some malignancy related lymphadenopathy.
Okay, what kind of malignancy is possible at this age and the patient profile?
Yeah. It could be lung malignancy. It could be GI malignancy. Yeah.
Okay, all right. Is there any other differential diagnosis than SIADH?
Mm. The patient also had history of a fall few as the son described. So I will also think of chronic S subdural hematoma in this patient.
Okay, but the weakness precede the fall, right? Instead of fall, then subsequent develop the weakness.
Mm. Mm.
So what might be any
Other
other differential diagnosis to explain the patient?
yeah,
Hmm.
other could be disease like Addison's disease,
Okay, hypocortisolism, adrenal
hypocortisolism,
insufficiency,
adrenal
and then
insufficiency.
any other thing?
It is mm, mm, poor intake.
Poor oral intake, hypovolemic hyponatremia, is it?
Yeah, yeah.
Okay. Any other thing? Then you have mentioned about adrenal insufficiency. You have mentioned about possible SIADH.
What else?
You asked about some weather preferences as well, right?
Yeah. So hypothyroidism.
Hypothyroidism is also a possibility. Okay,
Yeah.
good. How will you investigate this patient?
For investigation, first I will order a complete complete blood count, urine renal function test, including level of the electrolytes and urine REME to look for and
Urine what? Sorry?
urine routine test,
Urine FEME. Okay.
urine FEME, and urine osmolality, serum osmolality for this
Okay.
patient, chest imaging in form of X-ray and HRCT, as well as CT of the abdomen for any
Oh, so far
malignancy.
CT, yeah? So far CT scan.
So,
Is
yeah.
there anything you want to consider standing first before you order a CT scan which carries risk of contrast?
Risk of contrast. We can do the ultrasound of the abdomen
Okay.
and stool for occult blood
Okay,
for
good.
malignancy,
Okay.
and yeah,
How
blood
to
sugars.
exclude your differential?
Sorry.
How to exclude your differential? Any
Um,
investigation you want to send?
yes, for hypothyroidism, I will have to do the thyroid function test. For chronic subdural hematoma, I will have to order the plain CT scan of the brain.
Okay.
Yeah.
There's one more, right? You mentioned about Addison's.
For Addison's, we'll have to order Schwarzenegger test
Sorry,
and serum
Schwarzenegger test. What is the
cortisol.
screening test?
Sorry,
What is the
serum
screening test?
cortisol.
Okay, when the cortisol is going to be taken?
9 a.m. cortisol.
So it's a early morning cortisol,
Early
right?
morning cortisol. Yeah.
Mhm. And if it's indeterminate, then you proceed with Sinectin. Okay, all
Yeah.
right. How will you manage this patient?
For the management, I would first classify if this is the euvolemic or hypervolemic or pseudo hyponatremia for this patient. And first, I will if the patient is on respiratory, so I will first
Time's up.
secure ABCD. Yeah.
Yeah, but you can continue. Let's say this patient is euvolemic hyponatremia.
Mhm.
How do you manage this patient?
Euvolemic hyponatremia. First, we should try to restrict the restriction, and can give NSAID. Oh no, NSAID not
And
NSAID.
said,
No. Yeah, I think the fluid restriction would be the beginning.
okay, that is just for the hyponatremia fluid restriction alone. How
Mhm.
about identifying the causes of it?
Yeah, identifying the cause. I'm sorry, I did not get the question.
Yeah, I mean, you say the cause of SIDH can be due to malignancy, right? Undiagnosed
Yeah.
malignancy.
Yeah,
So how
so
do you
I'll
address this
yeah.
issue?
Yeah, we'll involve as a multidisciplinary team. I will also involve the pulmonologist and gastroenterologist in this patient. And if there is any lung malignancy, and try to classify if it's resectable or not. And if it's resectable, then I will refer to this operating team as well.
Okay, and also bear in mind that we do that. We write in that we write this plan in our in real life. Let's say something like in sodium increment less than 8 millimole per liter per day. But bear in mind that in exam also we have to make sure that we mention that, because overcorrection for hyponatremia will actually cause osmotic demandancy.
Yeah, CPM. Yeah.
CPM, yeah. So it's
Mm.
very important to mention that as well. I mean, ODM is an old term. Now we call it CPM. But
CPM, yeah.
actually, there's also extra pontine myelinolysis syndrome as well in
Yeah.
severe case. So yes, okay, all right. So I think we'll end the session for your case. So how would you do you encounter this scenario before?
No, doctor.
Do you know this exact same scenario is actually extracted from RCP official website?
No, doctor, I did not.
I actually take the same scenario, but I change a bit in terms of the diagnosis, because the actual diagnosis, if I calibrated as such, I think a lot of people will not able to get it and may fail the exam. And that's how difficult it was. So actually there's one more differential that you didn't include, which is important. And I don't think anyone will routinely include in that unless you encounter such a scenario before, or you really know about the drugs. You know what medication the patient was on?
The patient was omeprazole, yeah.
Omeprazole. Do you know omeprazole can cause hyponatremia?
I think I've heard that.
You heard that, right? In fact, this is one of the known side effect of omeprazole. In particularly in terms of PPI, omeprazole have a higher risk to cause hyponatremia. And this is one of the known side effect, and it was also written in the NHS leaflet. And actually, if you look back at the official website to look at the sample scenario under PACES 2023, they have this similar scenario, and the scenario they calibrated as a primary differential, the primary diagnosis was actually hyponatremia secondary to omeprazole. Are you shocked? Yeah, you're
Yeah.
shocked, right? So you can see that the RCP actually want to calibrate the scenario like that. And the second differential they give was actually SIDA secondary to GI malignancy. Okay, because got some red flags for the GI symptom, as well
Yeah.
as a SIDH. So I think the pitfall for you in this station is you didn't assess the volume status. It's very important. You must measure. You must mention check for pulse volume, skin turgidity, capillary refill, and also the lips, as well as check for the periphery whether it's warm or cold. Because if you do that, then you can say that this patient is euvolemic, or else you will not able to tell that this is hypo, or euvolemic, right? It's difficult for you to get a differential. So it's important. For this scenario, I was quite surprised because I didn't expect SIDH can come out in the real exam until I just browsed through the RCP. Sometimes they will change their sample scenario because they just change their format. So I just looked through their format, and in fact, this scenario was stimulated in their YouTube channel as a part of the calibration and also the sample question. So you can see that the candidate and the examiner discuss about this case. The examiner discussion was also about this case, and they actually calibrated SIDH first and then also by PPI, in which I think is fair. To me, I will also calibrate as SIDH secondary to GI malignancy or some form of malignancy, and then maybe the differential will be the omeprazole induced hyponatremia. Okay, but the real scenario, the first diagnosis, they actually put hyponatremia induced by the omeprazole. Okay, so I think you are okay. You're able to get the discussion well, and then your history wasn't a big issue. In terms of your, if I omit the differential diagnosis, probably will get borderline. The rest of it, I think you can get full marks. But again, this is a virtual exam, a virtual practice. In real life, I don't think you have time to go through, to examine for visual acuity, to go for visual confrontation test to check for not visual confrontation, the H test to check for EOM, examine the lymph node, yes, examine the neck, examine the heart, examine the lung, perform a neural examination, only perform the abdomen examination. Again, you don't have that much of time. because this is a stimulated virtual practice session, I will just tell you yes, no, very fast. Imagine you're doing that in the elderly that turn their body position also takes about 20 seconds. How are you going to do that everything in one go? It's not possible to do it in exam. So again, back to the point, when you encounter any scenario for consultation, you should choose the things that you want to examine most. You think that if this is an examiner, is the examiner concerned of the neurological examination? Definitely not, because it's generalized body weakness. Okay, you're not worried about stroke. Okay, to cause both side body weakness and generalized. So your definition of calibration is not focusing on neuro. You can offer to do MMSE, which is not wrong, or the William score, which is that there's a few the what you call the 4AT thing, but that is not the whole point. I don't think examiner will calibrate as such. The examiner definitely, if I'm the examiner, I'm definitely going to calibrate this patient. First thing is the uh hydration status, the volume status. That's definitely thing that I want to know. Okay. Second thing is you want to know whether patient got any features of hypothyroidism, because the patient elderly can present as hypothyroid, can be very non-specific, may not fulfill all the all the cold intolerance, all the like weight gain, everything. So may not be very classical, but patient can be hypothyroid. So I will want to check for the thyroid status, feel for the neck. This for sure. Okay. And the third thing, what are the other possibility is that can it be adrenal insufficiency? So for this kind of patient, I will ask if patient can stand. I will also offer to check for postural blood pressure and check for any pigmentation over the lips, over the mucosa, over the hands, especially the fingers, to look for adhesions. Okay, although it's not common to present at this age, but it can also be secondary adrenal insufficiencies because of other reason, like for example, drugs or pituitary. So that's why I also need to check all that. For this kind of patient, I will also check for whether there's any buccal pigmentation, as I mentioned earlier, or also any form of oral candidiasis. Okay, elderly immunocompromised, adrenal insufficiency, we also always need to check for whether there's any buccal candidiasis. Okay, so another thing that I would say is important to calibrate is the abdomen examination, because the red flag is not in the lung, the red flag is not in the prostate, or the red flag is not in the bone, for example. The red flag is actually got some indigestion symptom, okay, swallowing issue not much, but the indigestion symptom and also abdominal discomfort, bloating. So all those with the weight loss, all those things point towards more to abdo. So I will definitely offer to do an abdominal examination. Okay, so it's very important for abdominal examination because want to look for any hepatosplenomegaly. At the same time, we also need to check for the bowel sound, make sure no constipation. Another thing is that no one, most of people will forget, which is the colorectal examination. So no one actually mentioned about colorectal examination, and Dr. Abi, you didn't mention about that as well, because patient 3 years ago have a history of lower GI bleeding, although the diagnosis was told to be diverticular disease, but the last scope was done 3 years ago. So definitely you want to make sure that the patient does not have any form of colorectal bleeding. Okay, so definitely PR, I think you should mention, especially if you're thinking of cancer, malignancy. Okay, you should screen. Can be colorectal carcinoma, sometimes can be detected as well. So that will be it for examination to me. Okay, in which I will not go into lung, I will not go into the heart, I will not go into the neurological examination at all, because I will focus on the important thing for this scenario. Okay, unless patient got focal neurological symptom, then yes, we have to examine the neuro, in which this scenario I don't think is relevant. Okay, and if you really got time after you do what I mentioned earlier, then you want to examine lung or heart, it's fine. You got time, then you can do it. But the main idea is to hit the main dish first. Don't go all the side dishes, and then you didn't able to score the physical sign in their marking scheme. Okay, so just to calibrate back the scenario, yes, you got most of the history. Adrenal insufficiency, I realized that this scenario you didn't try. You did ask about fever, lah, but didn't try to rule out any signs of infection other than the fever per se, lah. You should also ask a bit more whether patient, you ask, I remember you asked about cough because you want to screen for lung cancer. But other than that, you also need to screen whether there's any, you mentioned the patient is on diapers, right? So you want to also ask whether any foul smelling urine or any frequent change of diapers, Okay, and all those things can actually any pain or when pass out urine, things like that, to actually suggest any infection, like for example UTI. Okay, and because of got this poor concentration, you may also want to ask whether any stiffness over the neck, any do you think that she's agitated to the lights to suggest like meningitis, for example? Elderly also prone to have infection like meningitis. Okay, so other than that, I think you are pretty much sorted. And then the differential diagnosis, definitely, even for euvolemic hyponatremia, also the differential diagnosis should be SIADH, hypothyroid, as well as adrenal insufficiency. So same goes to this scenario. These three must be there. Okay. And drug-induced hyponatremia like omeprazole is something have to keep at the back of our mind, because RCP calibrated this scenario as such. Imagine all the audience that listen to this recording or even live. Imagine you are Dr. Abi. Will you able to give this diagnosis or not? If the answer is no, then you really need to now aware that omeprazole induced hyponatremia actually is part of what RCP can calibrate. Okay, so you can see that sometimes the scenario may not sound difficult, but the answer is quite difficult to get if we don't know about it. Okay, so you should also mention about pair sample, TFT, AM cortisol, scope, fecal occult blood test. You want to do a tumor marker, not wrong, but it's not much of prognostic value unless you able to localize a particular cancer, and then consider CT only later. That's why I didn't put it in the front, I put it way behind. Okay, if it's indicated. So if you think this is can be a possibility of drug-induced hyponatremia, other than emission, strict IO charting, everything, you may consider to stop omeprazole and consider alternative, because the indication to start omeprazole for this patient is not very strong. It's just because of indigestion. You can consider switching the patient to H2 antagonist. Okay, that can actually avoid all the side effect of omeprazole as well. So you can also refer to gastro team for further opinion, and then further GI screening. Okay, and then food balance charting, avoid rapid correction, refer to endocrine if indicated. So all those things I think we all can goreng and mention. We can just discuss through. But the main idea is to get the diagnosis correctly, get the investigation, get the history properly, and then examine the most appropriate examination. So the tips for consultation is usually there will be a station that is more predominant that you need to focus on. For example, like this station, because the red flag is more to GI, so you should examine the abdo. At least you feel for the tummy, feel for the liver spleen, okay, feel escorted for the bowel sound, ballot kidney, like that. Okay, usually we have a predominantly one station, one system like that. Let's say this is like a stroke patient, then definitely your focus is in neurological examination. Try to do some cranial nerve, upper limb, lower limb, just a brief one. If can walk, then get. Let's say this is a scenario of prolonged cough, and then got hemoptysis, you think it's TB, you examine the lung, so your lung is predominant. So you need to do more like chest expansion, and then percussion, and then auscultation, and then vocal resonance. So you need to do a bit more on particular system. So this is how we should do. Like let's say this patient has a psoriasis, for example, with psoriatic arthritis, joint pain, or even like ankylosing spondylitis. So the focus will be musculoskeletal examination, the rheumatological examination over the hand or the back. So we have to do a bit more detail. Okay, and the rest is just general peripheral examination and certain thing important. So my tips for today's session, since everyone, most of the people that attend today is either going for exam or preparing for the exam. So the new format, before you examine the patient, perhaps you should tell the examiner that what is the striking things that you found from the vital sign or anything. So let's say the patient is high BP, you should prompt to mention that, and notice that the blood pressure outside is high. I would like to order a repeat blood pressure as well as a postural blood pressure if indicated. So you should prompt the examiner. It's a method, it's an art that if you do like that, although some examiner may get annoyed, why you need to repeat is the same. So the old examiner, they don't like that. But it's okay. To me, it's fine, because the moment you say that, I mean, if it's abnormal, then you must mention that. If it's normal, you want to mention repeat is not wrong, but it doesn't give any clue. But for abnormal, too low or too high, things like that, you want to repeat the blood pressure, other than letting them to give a good impression that you want to reassess the patient. Okay. Second thing is actually the examiner knows that you are aware of the vital sign, because sometimes they will calibrate the vital sign as their positive sign. Okay, so it's important for you to mention that. Sometimes if you're already aware of all those things, but you didn't mention that, you just go through the differential, go through the investigation management. If you didn't mention that, certain examiner may consider you as didn't actually detect this positive sign. So it's very dangerous. So that's why I say to play safe, if anything abnormal, you mention it. Like let's say sugar is low, hypoglycemia outside the scenario. You mentioned that I want to repeat the blood sugar level, capillary, because I noticed the sugar is low, documented. So make the examiner aware. This examination is an art in which you need to have a bit of communication with the examiner and mainly to the patient as well as examiner. Okay, need to keep the things active. Cannot be like very passive. No, just examine, do your own thing and then tell the examiner what you find. Cannot be like that. You need to show everyone that everyone is participated in this exam. You know, the two examiners are looking at you, they are participating for exam. Patient also trying very hard, or surrogate is trying very hard to participate, to give you the answer, to give you the clues that they need to give. So you should take everyone as a participant. Okay, this is like a game. You go in, you make sure that you are taking part with the patient appropriate manner. Okay, don't cause unnecessary pain. Before you touch the patient, ask them whether you have any pain or not. Make sure that they feel like, and don't threaten the patient. Don't be considerate, be empathic as well. If the patient shows some emotion issue, it is specifically set as such to test your communication sometimes, even in consult. So you have to lower down your tone, speak to the patient slower a bit, and then ask her, is it okay, anything wrong, anything that I can help. You don't have to go in rush to got this or not, do you have this or not. I mean, we don't have to be so mechanistic or machine like style. We just have to be a bit more humane. You already prepare a lot for the exam. You go in, you don't have to show that you are a very knowledgeable person, but the main idea is to show that you are a very caring physician. You think everything as a whole, and then you do things in a simplified and concise manner. That's the more important thing. And you make sure that when you notice something is abnormal, if you like, let's say vital sign, everything, you just mention it's okay. Just mention that so that everyone is aware. Sometimes examiner may miss things that you examine. Okay, so that's important. Okay, so I think that's all. So probably the last slide before we end the session is actually I just want to make everyone aware of what is the complication or association with long-term use of PPI. I feel this is quite an important topic because a lot of times people say PPI can cause a lot of side effects. Some are proven, some are not proven. So what are the things that actually matters that we need to know? So I would separate into three components, which is electrolyte, GI, and chronic disease. So this, the one that I highlighted and the one that I listed is all proven. Okay, it's all proven. It is not like a what we call as conflicting evidence here and there. These are all proven. Okay, you all need to be aware about this association because a scenario can come out with, for example, B12 deficiency on PPI. It can happen, and you must offer the just same goes to metformin induced B12, right? PPI also can cause B12 deficiency, and this is something that you can offer as a differential. Okay, and PPI is also important because if you know all the side effect, then you know that uh certain scenario PPI can be the culprit because drugs, any change of drug, any addition of the drug, any prolonged use of the drug, all this can have some implication to the diagnosis sometimes. Okay, so it's important for us to know. So for PPI, in terms of electrolyte, hyponatremia, we just discussed, omeprazole tends to have highest risk factor as compared to esomeprazole or even lansoprazole. So omeprazole has the highest risk. Okay, so hypocalcemia is also another thing. So patient on long-term PPI can lead to malabsorption, and that can lead to hypocalcemia. And the third thing is hypomagnesemia, which generally also have malabsorption, but I don't think it will come out in exam. Hypomagnesemia presentation is more to cardiac arrhythmia, tetany, spasm, so can be very non-specific, which I don't think can come out in exam as a standalone scenario. But B12 deficiency, yes. And GI, the thing that is a hot topic is the C. diff. C. diff, we must know the association PPI with C. diff because we know that long-term use can predispose to C. diff. And not to forget about microscopic colitis. Okay, intestinal colitis, MDR bacteria. Some can consider PPI associated with SIBO, small intestine bacterial overgrowth. But generally, the overgrowth organism, if you look in detail, the literature is more to multi-resistant drug. It's not the usual gut organism. So SIBO and PPI is questionable, but SIBO with this hospital-acquired drug-resistant organism colonization, yes. Chronic disease, only two important things, which is the CKD as well as dementia. These two is all proven. to increase in odds ratio to cause long-term use of PPI can cause progression of CKD. And also PPI, we know that have a risk of acute interstitial nephritis, okay? And therefore it's also important to be aware. And then dementia. So certain scenario, we may need to include like changing the PPI or stopping the PPI for a while until we know what is the exact cause. So that's why I think it's important to know about that as well. Okay, so I think that's all for today's session. Anyone have any question? Abi, I forgot to ask you, do you have any question?
No, doctor, it's clear.
It's great, huh? Okay.
Yeah.
So probably this will be the last session before you all go for your exam. I would a few advice for me is that I would encourage those that going for exam. Now it's just like 1 week plus preparation time. It is very stressful, I would say, because you will be like don't know what else to revise. There's so many things to revise. If you want to revise again, your head is going to bloom. So what I would suggest is try to go through some of the things that you can prepare. For example, short cases, you can prepare the presentation. Try to present different scenario in different station. Try to have your own presentation. Just present like, for example, you are dealing with thalassemia. How do you going to present a thalassemia in a short case? Okay, I've examined this patient, blah blah blah. I think my working diagnosis. If you don't want to state the diagnosis upfront because you're not sure, just present like an abdomen examination. For general inspection, I noticed that the patient has tinge of jaundice. I have also pallor, conjunctival pallor, pulmonary pallor, and clinically I also palpate that there is a hepatosplenomegaly. On top of that, there's also some other things, for example. And then in summary, I think my differential diagnosis is chronic hemolytic diseases such as thalassemia. And then I want to offer other differential diagnosis, for example, hereditary spherocytosis and all those things. And then in terms of complication, I want to mention about what. So you have to go through all the template. So how do you know the template? You can follow the one that I have in my notes. So you all have to be very, very fluent in short cases. Short cases, the way when you go for exam, you should tell yourself that whatever cases you encounter, you should able to present it. Okay, you should examine and present it well. And also read up a bit on the discussion part for the Viva, because all those are the expected question that you can ask. What is the differential? How do you investigate? How do you manage? Very, very expected question. So like thalassemia, how do you manage? How do you investigate? You should really go through again. Make sure it's fluent. And then a lot of short cases can be prepared. Neuro is something can be tedious because you need to really choose your examination properly within the 6 minutes. You cannot examine everything. You just examine what is really important and what do you think the examiner will calibrate. Okay, whether it's cranial nerve, upper limb, lower limb, extrapyramidal system, which is a cerebellum, and also the Parkinson. To know all that, you can watch back the video in my YouTube, the one with the short case examination approach, as well as the neuro short case approach. Just go through the video, just go through, and then just revise back. I feel that the short cases is something that you must score. Short cases, if possible, you must score full marks for all. Okay, I score full marks for all except my neuro because I don't have time to elicit the dysmetria, unfortunately. So I was like bottom a bit, but almost full marks, I would say. So you must really train yourself to at least get a full marks in most of the station. Com skill, I would believe that if you all know what are the recent possible scenario that come out in exam, practice with your friends or even with other tutors, because like unfortunately I cannot commit for regular intensive course like that. So practice about the common com skill. Okay, now com skill is so short that it won't really give a very complicated scenario. Just go to the usual scenario. Okay, so other than that, I think com skill is fine. So other than that is actually consultation. The reason why I really keep on discussing on consultation scenario is because I want everyone to know what is the style and what's the expectation and what are the things that you need to be prepared. It's not just, cut history, examine, and then just tell the diagnosis. It's not as simple as that. You must have your own approach in dealing with different kind of scenario. So you must be sharp enough to detect things. For example, the third scenario of the young hypertension. Okay, you must be sharp enough to detect that. Okay, the patient is young and then the BP is hypertensive. So can this be young hypertension? So a lot of clues can be very subtle one. For example, they give you potassium salinity 2.3 with a lot of vital sign, with a lot of other blood results. So if you miss that potassium of 2.3, then you may not be able to get a diagnosis easily. So a lot of crews make use of the crew, make use of the exam rules. Okay, so that's the thing I want to convey lah. So I think that's all. A lot of thing to digest. So I hope you all, if you all think that you all at this time want to focus on revision, then perhaps it's also good to go through all the common topics, all the common approach, common topics, go through the approaches. So you should tell yourself, before I go for exam, I will prepare all the rheumato and the endocrine scenario. I will write down in the piece of paper. I will just mentally rehearse everything in short. Okay, I will tell that, okay, because all those, if this few scenario came in the exam for consult, it's going to be a bonus for us. You should treat that as bonus. But again, you only treat it as bonus if you have prepared enough, because the expectation is going to be high. For example, endocrine acromegaly, they will expect a lot of things. Not just acromegaly. For example, headache in acromegaly, like what Dr. Hassan mentioned in his video, can be few reasons, right? Can be due to pituitary microadenoma, can be due to OSA because of the OSA having early morning headache, can be also be due to, for example, what other causes for headache in acromegaly? Can also be due to what else? Certainly I can only think of two, but there's actually a three or four. Can also be due to pituitary apoplexy, for example, on acromegaly. So it's very important for you all to have a list of differential diagnosis and the approaches. Okay, so acromegaly, I will write what are the following my notes. What are the symptoms? What are the complications? What are the association? And then what are the things to examine? Okay, and then similarly for Cushing, for hypo or hyperthyroid, okay, endocrine, more or less settled. The rare one you can just go through, like carcinoid, all those may not be so common to find those patients easily. So most of the center will not able to get this kind of scenario. So other thing like rheumato, easy to prepare. Everything is like very spot on, right? Rheumatoid arthritis, scleroderma, especially scleroderma can come out like very easily. So scleroderma always offer a differential as mixed connective tissue disease. Don't forget this as a differential. And then other thing, a lot of other rheumato is quite natural, like ankylosing spondylitis, the back pain, the seronegative spondyloarthropathy, and the IBD, for example. And then go through each system, those common scenario. So if you go by this approach to revise for the remaining 1 week, you should cover most of the thing in general. So I think, again, all the best to everyone going for exam. Hope for good news. Even if you all success, the success definitely not come from me. It's come from you all and your efforts. Okay, but don't be too stressed. Try to really go through things slowly, and then 1 or 2 days before the exam, try not to sleep too late. You really need the attention span. You cannot be really insomnia until the next day. You go for exam, you're already very, very tired. And certain people recommend you to take some beta blocker because of too anxiety, verbal diarrhea, things like that. I would personally advise against it, because you should be yourself. You should just present your natural self. Okay, you don't have to be too tired, too anxious, because just treat your normal practice as an exam. Just like in exam, you just treat it as your normal practice. That's how your mental status should be. Because I got a few experience, I mean not me, but from other seniors, that some of them, they take beta blocker, they really become, their effect is really blunted, like very, very blunted, very slow, and that really affect the exam performance. If you are someone that never tried this kind of medication before, better don't try it. Okay, first, you are naive to it. Second, side effect, you may not able to tahan. And third, definitely don't want to affect your performance. So just be yourself. Just go in, tell yourself that I will try my best. Most of the thing, you go inside, nothing you can change already. It's mainly just luck. So you just need to try your best and show that you are a very caring doctor, and then you are capable. You have tried your best to find a diagnosis. At the same time, you understand your limitation. If you don't know anything, you're not sure, and then you say, I'm not sure, unfortunately, sorry, but I will keen to know. I will want to know further, or get my superior for input, things like that, to show that you're at least enthusiastic. If you are not smart, then at least enthusiastic. Okay, that will be my final say. Okay, all right, I will just close the recording. Thank you so much for attending. Yeah, thank you, Jeremiah. Okay, bye. Just close the recording first.